So my job really is to kind of give you the context of the history so that the discussion is productive for all of us. So we have a 62-year-old woman who originally presented in July of 2014 with some systemic symptoms of thyroid eye disease, specifically some shortness of breath, and she's in ophthalmology. And initially she presented with some intermittent diplopia and some eye injection. The eye was firm to retropulsion on examination. She did not have proptosis at that time, and definitely no optic neuropathy. At that time, we treated the dry eye symptoms and the irritated eye symptoms with humidifier, some head elevation and lubrication, and she was prescribed Voltaren systemically and ketorolac drops. Endocrinology saw her again in March of 2016 and noted that she had pretibial myxedema, and they were wondering whether this was kind of erythema nodosum versus pretibial myxedema, but they treated our patient with prednisone and tapered that off. This is the visit in April where we started to be concerned about the thyroid eye disease and its manifestations. The visual acuity had dropped from normal to 20/70 on the right and 20/25 on the left. And as you can see, the pressures in primary gaze and upgaze are very typical for those that are seen in thyroid eye disease patients with elevation in upgaze. And we first, initially, for the first time, actually saw an RAPD on the right. There's just some data here to suggest that there are indeed features of thyroid eye disease, and concerningly, color vision on the right had dropped significantly to 0 to 10 Ishihara plays. Critical flicker fusion frequency was also asymmetric, again indicating the right optic neuropathy, and there was some mild pallor of the optic nerve on the right. This is the motility here, and you can see that there is an esotropia and right hypertropia that's seen in primary gaze. And again, very typically, upgaze restriction in both eyes. So I think this is probably the most important part of the talk, and this is the visual fields representing the significant optic neuropathy that's developed. So the first field is from February of 2016, just a kind of initial presentation to us, which is really reassuring, but as you can see, the fields begin to progress. And in May of 2016, especially on the left, you see the visual acuity dropped to 20/250, and you're starting to notice that there's some visual field deficit noted on the left as well. This is an MRI that exemplifies the features of those axial and coronal T1 post-gadolinium fat suppression sequences, and these are meant to show you the significant enlargement of the extraocular muscles with compression on the optic nerve, and the same is seen on the other side as well. So just to go back to the fields there, how did we address this and how did we treat this? In April, after the first note of the right compressive optic neuropathy, we treated the patient with methylprednisolone 1 gram IV once a week for 3 weeks. And she required an orbital decompression, which involved the medial and the lateral walls, as well as some lid surgeries at that time. So the story goes on, and we note that later in May, we still have continued visual field progression. As you can see, both right and left are involved. And further on, again, we see further progression of the compressive optic neuropathy bilaterally, and the middle field there is done in June of 2016. So something clearly needed to be done at that point again. And on July 1st, the patient underwent again a repeat bilateral medial and apical orbital bony decompression, as well as partial ethmoidectomy at the time. In addition to that, retrobulbar steroid injection was given in both orbits. In July of 2016, in addition to the surgery, radiation was administered to the orbits. And the examination in August of 2016 showed actually improved visual acuity in both eyes. The pressures were still within the normal range. There was an RVPD noted on the left. Color vision had improved, and critical flicker fusion frequency had improved as well. The cover testing did show esotropia of 35 primary gaze, which is again increased from the previous measurements. Now, bilateral optic nerves had some temporal pallor. So that is kind of a quick run through the history. I have some suggestions for discussion, but I thought maybe we'd get Dr. Feldman to come up and discuss the case from his perspective, offer his suggestions, and we can go to the discussion questions if needed.
Thank you. I'm delighted to be here, and it's nice to see a lot of old friends and meet some new ones. And I hope that some of you were present last night and talked a lot about potential new therapies and some of the frustrations with our current therapies related to thyroid eye disease. One of the things that's most interesting is that the incidence of this severe disease is actually going down. And whether that's due to people no longer smoking, or whether it's due to some other environmental factor, or perhaps we're just better treating hyperthyroidism, we're detecting it earlier, and I think that that may also be a factor. The philosophy about thyroid eye disease are myriad, but the treatments are pretty stereotyped. I think that in patients who are not otherwise at risk, giving radioactive iodine to treat the thyroid condition, I think is perfectly reasonable. And this tends to be sort of a local phenomenon. So when I was in Los Angeles, 90% of my hyperthyroid patients were treated with radioactive iodine. Now in Rochester, maybe 5% are treated with radioactive iodine. So there's a lot of variation, which means that nobody knows exactly what the best treatment is. But I think it's pretty well established that patients that have radioactive iodine do have a slightly increased risk of developing eye findings. I think that that's been established in class 1 type studies, prospective studies, and also the patients who have thyroid eye disease that's mild tends to get worse when they get their radioactive iodine. So there's been, I think, a pretty much consensus that patients who have risk factors should be on low-dose corticosteroids for perhaps a week before and perhaps 2 or 3 weeks after the time to get radioactive iodine. 20-30 milligrams of prednisone per day, and certainly not enough to get all the long-term side effects and not high enough dose to have short-term side effects. And I think that that's a good practice, and I certainly recommend it to my patients. So the question here is, well, were there any risk factors? And so our patient today, had a remote history of smoking, like in the 70s. So it's really hard to say that is a big risk factor. The biggest risk factor is probably age. And so when you see patients that are in their 20s and 30s, which is the peak for hyperthyroidism, I think that if they're non-smokers, I think we really have no risk factors. But once you start to get into the 50s, then I think that the risk of developing eye disease does go up, and that there may be a little stronger case, even if somebody has no eye findings at all, for prophylaxis with low-dose corticosteroids during that time. So that's one thing. Radiotherapy versus for compressive optic neuropathy versus using decompression. So last night I mentioned that when I first started in practice in the late 1970s, we had an armamentarium that consisted of high-dose corticosteroids, orbital radiation, and orbital decompression. Today we have the same exact things. So we have made, in terms of progress, a a lot of new potential treatments coming on the market, but none that have really displaced the mainstays of therapy. And there's a lot of controversy about the role of radiation, orbital radiation, and there's a very thoughtful group that basically any patient, as soon as they start to develop any kinds of inflammation or periorbital inflammation, they're going to go and get radiated. And then there's another group that radiates a patient maybe once every 3 years when they have terrible optic neuropathy. So there's no consensus. The prospective clinical trials related to orbital radiation for thyroid eye disease, the one study that came out of the Mayo Clinic showed no effect. But on the other hand, they were sort of taking all comers, and it was unclear what degree of inflammation and where they were. And that's the problem we have with all of our patients in terms of trying to do studies. No two thyroid patients are the same. And so their endpoints are all different, and where they are in their disease is different. And when what we call severe thyroid eye disease, like our patient today has, is not, we say, well, that's active disease. Well, it's not active, it's progressing in terms of symptoms and signs. But the activity is probably long past. There's probably not acute inflammatory responses going on. What we're seeing is scarring and the effects of increased tissue within the eye socket, the pressure effects that I talked about a little bit last night, as well as the fact that the orbital fibroblasts, which are activated, are integral to disease and either turn into fat tissue or into scar tissue, and then elaborate hyaluronan, which brings in a lot of fluid, which raises the tissue pressure and produces some ischemia. So as far as radiation, the only real contraindications that I see to using orbital radiation is if the patient's diabetic or has other severe vascular disease. Those patients do very poorly with radiation, and I wouldn't recommend it. But in the absence of that, I think that this is a perfectly reasonable thing to do. The question is, well, should you use the radiation and steroids first, or should you have done them after decompression? I would have done it the way that you've done it here. Decompression works to alleviate optic neuropathy somewhere around 90% of the time, especially in terms of color vision and visual acuity. A little bit less so in related to visual field, about 70%. So that's better than what you get with radiation and steroids, which have to be given together. And also, if patients are already toxic from steroids, you're prolonging their steroids by giving them radiation as opposed to doing decompression, where oftentimes you can take them off for steroids. So in terms of what the new options are, I did publish one patient who, who had a course very similar to our patient today, who progressed to decompressions, and finally I put her on Celebrex, which I talked about a little bit yesterday, because it's been shown to really inhibit the reactive response, the inflammatory and immune response in thyroid eye disease. And actually, that patient did better on Celebrex and recovered vision, whereas on steroids was losing vision. So there's one other thing. We don't have postoperative CTs or MRIs here, so it's hard to know what the first and second orbital decompressions do. But and I use different techniques, so which bony walls are decompressed may be slightly different. But in the patients where I found that they initially got better after decompression and then got worse again, what I actually found is that the posterior wall of the maxillary sinus was kinking the nerve as it was coming into the orbit. And so you have the inferior rectus will look like it's a hammock, it falls down, but it's being held up by the posterior wall, and so it's kinked at that point. And when I've gone in and taken out the posterior wall of the maxillary sinus, then the optic neuropathy got better. And so I think that it's very important for our patient today to really go back and study those scans and make sure that you haven't produced a secondary cause for the optic neuropathy. as opposed to just having not enough overall decompression. It can be very focal, and 10 minutes worth of chipping away a little bit of bone, and I tend to use a transaxial route, which gives me access to everything but the roof. And that would be the other option for this patient. Patients who I've had who have failed on 3-wall decompression, Dr. Nassiter, a neurosurgeon, popularized the Nassiter procedure, and it is a transcranial orbital decompression. And those patients that I've had that have been recalcitrant like this, with this kind of optic neuropathy, they have done well with transcranial orbital decompression, and that's the experience of the Mayo Clinic group as well. So I think that you don't want to wait too long if you're going to consider this route, but getting the entire orbital roof removed all the way back and unroofing the portion all the way back to the canal is something that might be considered in this particular patient. Well, obviously I can go on and on and on, but I think that this is a very concerning and not that infrequent issue that we deal with. Our patient is still on 30 milligrams of prednisone per day, and if she is, that's now you're producing a secondary disease. It'd be nice to find some sort of acute intervention where you could get off the steroids and get back onto the non-steroidal anti-inflammatories. Any questions?
In terms of the order of doing the decompression or the radiation, some of our orbital people have said that the tissue in the orbit is just different after radiation treatment. And when you're going to be doing a decompression, it just doesn't behave the same way. Has that been your experience?
Well, I think that's sort of true in some cases. I think the problem is when you get really elevated tissue pressure, you get fat necrosis. And that's what you're really seeing, is you're seeing the effects of chronic high tissue pressure, and you're getting fat necrosis, and then you get this sort of gritty, fatty, fibrous tissue stuff. Whether it's the radiation that enhances that or not, I really don't know. I prefer surgery before radiation. There are many people who do just the opposite. The real question is how many people didn't need to come to surgery if they had orbital radiation? And the answer is actually none. And the reason is that all those patients end up with orbital decompression anyway. The difference is instead of having it acutely and under all sorts of stress, it's done electively in order to start the restoration process. Any other questions?
I just wanted to add that the benefit that you get from radiation really is not immediate. As a matter of fact, you can really kind of stir things up a bit. So you have to be prepared for there to be more inflammation with the acute radiation, and then hope that over the next 6 months, the things really quiet down from the radiation. So if you're in an acute vision loss type setting, I think that what Steve said is very apt, that there's going to be a decompression happening.
And so absolutely. The other thing is that the experience that the Europeans have had with IV pulse therapy, weekly therapy, is very much different from what we have here in the United States, where they were talking about complete resolution, reversal of changes, all this stuff. We just don't see it. And in the high dose that they were using, 8 grams, there was an unacceptable incidence of death from high dose prednisolone. I mean, it's not a lethal disease, but there was lethal treatment that was advocated. Now with the lower doses, and the recommendation is about 6 grams. But the patient's getting worse while you're watching them. That's not it. Personally, I prefer oral steroids. If they're not going to get better within 2 weeks on 100 milligrams of prednisone, and I can manage them and taper them, they're off to the operating room, and then we'll see what we get after that. So there's no one way to manage these. Our patient here today has been managed beautifully. I think that there's still more work that can be done.
Hi, my name is Tara Hahn. I'm a resident here at the Moran Eye Center, and I'm going to be presenting a case of neurofibromatosis type 2. So this is a 12-year-old girl who was originally diagnosed with neurofibromatosis type 2 in June of this year. She presented to the neuro-ophthalmology clinic for a baseline eye examination. She was referred by ENT. She had no subjective visual complaints. Her imaging was reviewed and revealed a left acoustic neuroma, right facial nerve tumor versus an acoustic neuroma, and bilateral small trigeminal schwannomas, as well as a left cervical spinal schwannoma. Her ocular history was significant for a history of myopia, but no strabismus, and it had been noted that in the last 2 to 3 years, it was difficult to correct her visual acuity to 20/20. She has a surgical history of a right cochlear implant and a left craniotomy for excision of the acoustic neuroma. Her family history is negative for neurofibromatosis or for hearing loss, but her father does have keratoconus. Her best corrected visual acuity was 20/40 on the right with pinhole and 20/25 on the left. There was no APD in either eye, and her extraocular movements were full. Her right optic nerve showed slight elevation superiorly and nasally, and in all quadrants in the left eye. Her vessels were noted to be tortuous in the left eye. There was no red desaturation in either eye, and there was full color vision in both. Her Hertel measured 22 millimeters in both eyes. She had an esophoria that was worse in right gaze. She was also noted to have a right head tilt on exam, which was not consistent with the photos that were reviewed from 2 years ago. She had a left beating nystagmus in primary gaze, which was small amplitude and low frequency, and she had an upbeating and left beating nystagmus on fundus examination. Because of the abnormal appearance of the optic nerve, ultrasound examination was obtained, which showed calcified drusen in both eyes. This is axial T1 post contrast with BATSAT, which shows bilateral vestibular schwannomas here. And, this is T1 pre-contrast, and you can see the abnormal appearance of the left lateral rectus muscle here. And this is again post-contrast, so you can see enhancement of the left lateral rectus muscle. And then also, as well as enhancement of the soft tissue surrounding the left lateral rectus. This is an example. She has a cranial nerve 3 schwannoma enhancement there. Enhancement back here. This is diffusion, which again shows some enhancement in the area of the left lateral rectus and ADC. And this is T1 post-contrast. This is a CT coronal. Unfortunately, there were no coronal cuts of the MRI scan, but you can see here that the left lateral rectus is enlarged, especially compared to the other rectus muscles on this side. So our questions are, what's the next step in her case? What's the reason that she isn't seeing 20/20? Is it because she has nystagmus? Could she possibly have an optic neuropathy? And is the left lateral rectus mass concerning, and should a biopsy be pursued? And then there was originally some concern with the radiologist that maybe she had an optic nerve sheath meningioma on the right. Subsequent review, they didn't think that they saw it, but is there any evidence of that? And then I'll just quickly talk about neurofibromatosis. So there's type 1 and type 2. Type 1 is much more common. It's associated with capillary lake spots, neurofibromas, axillary freckling, optic pathway gliomas, leash nodules. And then neurofibromatosis type 2 is associated with meningiomas, schwannomas, cataracts, epiretinal membranes, and ependymomas and astrocytomas. So NF2 is a multiple neoplasia syndrome from mutation of NF2 suppressor gene. Bilateral vestibular nerve schwannomas are pathognomonic for NF2, but schwannomas of the cranial nerves, spinal nerves, or peripheral nerves are also associated with NF2. Meningiomas, ependymomas, and astrocytomas can occur, but neurofibromas are actually usually very rare in NF2. Several studies have noted that the first ocular manifestation of NF2 in the younger population is visual loss or diplopia. Posterior subcapsular cataracts or peripheral cortical cataracts are common, but these may or may not be visually significant. Epiretinal membranes, optic nerve sheath meningiomas, retinal hamartomas can all occur with NF2, as well as optic disc gliomas, which, as you saw, are associated with NF1 as well. Motility disorders can occur as a result of tumor growth, and then peripheral facial nerve palsy resulting in exposure keratopathy can occur. And this can either be from involvement of cranial nerve 7 or enlargement of a vestibular schwannoma or cerebellopontine angle tumor. And then here you can see this is anterior posterior subcapsular cataract, retinal hamartoma, combined pigment epithelial and retinal hamartoma, and then an optic nerve glioma.
Well, this is a very unfortunate case, obviously, for this young girl. So in terms of what the next step is, I think that in terms, there's really no urgency about doing anything related to the eyes right now. This patient has multiple lesions and they're large and they're producing issues all of their own. So the nystagmus, of course, is probably cerebellar induced rather than related to diencephalic type, seesaw or something like that, and probably not due to lack of vision. So I think we're probably looking at nystagmus, and nystagmus can blur the vision depending on how much it is in primary and whether there's a good null point. It can certainly cause blurred vision in 2020, 2030, 2040, and you can have a perfectly normal afferent pathway. So it's hard to know, what the 2030 means without actually examining it in a little bit more detail. We know that she has optic nerve drusen, and I'm not aware of any relationship between NF2 and optic nerve drusen, but it is curious that they're occurring. The things that I've seen in optic nerve drusen that are, of course, concerning is that here's a patient who could have or may have had or may in the future have increased intracranial pressure. And I think the combination of drusen with increased intracranial pressure does have a high risk for vision loss, more so than either one alone. So I think that's something to keep in mind, that if the early shunting, if the pressures are noted to be high, is something we may want to consider. Is the left lateral rectus mass concerning? Well, yes, all the masses she has are concerning. If you're asking me, well, what do we think the tissue type is? I think that's probably less important because it's probably a neural-derived tumor. So it's going, and we know that meningiomas occur preferentially in NF2. So is this an orbital meningioma? I didn't really see any bone hyperostosis or erosion. It looked like it was mostly contiguous with the lateral rectus muscle. You wonder if it may be some sort of a plexiform neurofibroma involving the lateral rectus, and so if you went into biopsy, you'd actually be biopsying the muscle, and that might be reasonable if you were concerned about the diagnosis or whether this could be considered a malignancy. But I think mostly it's a matter of curiosity. That's not her major issues right now. And if you needed to, if she stabilized, she doesn't have, she has no deviation, I believe, in primary gaze. She only has a problem with eccentric gaze, so she'll use a slight head turn. She'll be completely adapted. If she were to develop diplopia or start to, she's too old to think about some sort of amblyopia, but if she were playing with diplopia that was significant, I think you would do muscle surgery and just take care of the deviation, or perhaps do a fogging procedure in the other eye, some way of trying to mitigate the eccentric diplopia. But I personally don't think it's necessary to biopsy it at this time, and certainly if you excised it, you'd be excising the lateral rectus, which obviously is not going to do very good. Is there an optic nerve sheath meningioma? Well, there certainly didn't seem to be an obvious optic nerve sheath meningioma, and optic nerve sheath meningiomas aren't usually associated with optic nerve drusen, and so I don't think that that's the relationship. Sometimes in optic nerve sheath meningiomas, you'll get swelling of the optic nerve, and you'll get these cytoid bodies, which then can calcify, so you sort of have not actual primary drusen, but sort of secondary drusen. And so I don't know what to do. The problem that I've run into in a couple of these patients as they age is that they have de novo tumors. This is not watching an optic nerve sheath astrocytoma that's getting a little bit bigger over time. This is new lesions occurring all over. And of all the lesions that were mentioned, there were several others in the imaging that were there that weren't mentioned. I think there was a problem with cavernous sinus. There's a whole bunch of problems, and you're not going to keep up with this as you have nerve growth factors that are still active and haven't been shut down in any, from causing the damage that they cause. So it's a very concerning case. It's certainly unique, as many of these cases tend to be. They all have unique presentations, but I don't have too much more to offer in terms of management of her disease.
Other questions about?
And F2 always shows up on the OTAPs and always shows up on the boards.
Thank you, Dr. Feldman. That discussion was just excellent. Those were two great patients. So we're going to go ahead and get started with our actual. While Randy is filling this out, it's my great pleasure to go ahead and introduce our next speaker, our chairman, Dr. Randy Olson. And we'll go ahead and maybe Dr. Olson can do some of his introductory comments that he didn't have a chance to give while we're working on getting his lecture out.
So I apologize. I had an interview I had to do. It was one of those things that they said you gotta take care of at least one part in here. So I missed my good friend Steve Feldman opining on what he does so well on. Steve, it's a pleasure to have you here. And Steve and I have worked together in AUPO for many, many years. He continues in that role. In fact, we traded each other when we were presidents. And a person who's an amazing administrator, an inventor, and a great neuro-ophthalmologist. It's just an honor to have him. So, yeah, we get on the screen. All right, well, I'll just do some twisting and turning. Let's see, that's my advancement right there. All right, good. All right, so first of all, let me just talk a little bit about why we have this today and what's ongoing here. As you know, this was a meeting that essentially we call it Clinical Faculty Day, and we certainly have good people. We have some people that are here today that are going to do that. But my thought is that we have so many great researchers here. We've got so many people on the clinical side who are doing great clinical research. And what we often have lacking is communication between both sides. I'll hear people say that so-and-so got an award, and they'll say, I never had heard anything that they've done before. I don't know what's ongoing, what's happening. And that's a mistake. And there is a general thought that oftentimes that things have become so specialized in area that there is no ability to communicate. And I think often what's really happening is there's a dearth of interest or desire to communicate, and that therefore becomes a de facto truism that we lose the ability to understand each other. And so we want to have this a fairly even mix. We want people to sit down and talk. And I do know in some cases, in some of these areas, it may be a little difficult to understand the core concept. But I think that if we all try to make sure we're speaking in the lingo that is more every day, and we work hard at this. I think this can become a very important event so that we can understand a bit of the breadth of what's happening. Because I have that opportunity where I am to see and understand that and feel it, and I'm so proud of all that's going on here. But you know, we miss opportunities because oftentimes I'll hear about something and I'll say, well, you know, I see Alan Crowder. Well, Alan Crowder's working in that area where so-and-so in glaucoma. Well, I didn't know that. Well, we're not going to get the collaborations that are necessary until people do and understand. So this is our first, and I'd like to see this expand and move forward, and hopefully everybody will have a great time. So I'm going to talk about really a fairly simple, easy way moving forward, and something that's actually been incredibly productive. I want to start out, first of all, as we talk about this, that I've got a lot of colleagues here that are extremely important. I've got Jeff Petty sitting up here. He's been very involved in this moving forward. Frankly, Jeff Petty and Bill Barlow, I'm assuming, and the plan is they're going to be taking over the leadership and all of this as we move forward. Brian Zog's been very involved. Brian Stagg, had a lot of other residents. Ashley is now kind of taking over the leadership as we move this on the resident side. But it's an example of how it can be a lot of fun, and it can be very straightforward. And frankly, I think it's been the most important body of knowledge that's occurred in this area, certainly that I've been aware of during my career. So cataract surgery. What's the past been of cataract surgery? It's been a bunch of talking heads talking at each other, each of them saying that this is better than that, with no scientific basis whatsoever for what they're saying. And if you're in the know, like Nick is, and Alan is, and I am, we know who's being paid by A, or B, or C, or D, and we can all essentially guess what their opinion is going to be before they even say it. And that's been the state of the art of this field here for a very long period of time. So what happened is Griffin here, Griffin Jardine, did he make, he's one of our newer faculty members. Griffin? I'm giving you a shout out, he's not here.
He's out seeing kids.
He's out seeing kids, he's a pediatric ophthalmologist. He was a medical student, and I told him how frustrated I was. We've been working on a project, and I said, we need something that will sit down and tell us what works and what doesn't work in regards to cataract surgery. And we talked about it a lot, and I've got to give him 100% credit, because I'm a pretty good idea guy. For those of you who know me, I don't have a lot of time. And so he just wouldn't give up. And I'd say, let's try this, or let's try that. And he came up with what is affectionately known as the Cubinator. And it's really, really high tech. So I'm just pointing, this doesn't have to be something, you don't need to get $1 million piece of equipment. So what exactly is the Cubinator? Let's make sure. Yeah, there's the pointer. So the idea is that we need to determine relatively equal sized chunks of cataract material, relatively equal size density of cataract material, and then by having that and looking at it, we can determine two very important facts for fragment removal. So this is the fragment removal part of it, and that is, how long does it take to remove a certain size piece of material, and how often does it bounce off the tip, what we call chatter? Two very important clinical questions. Does that answer the whole issue of, and I get that in reviews all the time. No, no. But the perfect's the enemy of the good, right? You start out with something, and we'll talk about where we're moving now in regards to this. But at least for the first time, we can start debunking and objectively looking and seeing what makes sense in this field and what does not. So again, you take a nucleus, and we'll start out with human cataracts with Jeff Taven. Also a shout out to Jeff, was able to get us a bunch of hard, fresh human nuclei. You cut them into slices, and you cut them again, and then you cut them again, and you throw out the smaller ones, and you essentially get a 2 millimeter on a side cube. Now, are those exactly 2 millimeters? They're not exactly. Are they exactly the same hardness? No. But by mixing them up together and randomly selecting them, we can do 20 controlled experiments, have enough power to be able to analyze and compare. We're going to talk about some of this work that's happened. Testing is simple. You just bring them up in your regular little testing chamber we all have, bring it to the tip. How long is it there before it's subsumed? Time it. If it bounces off, you stop the timer and then put it on again, and every time it bounces off, it's a chowder. This is not, again, it's amazing that none of this had ever been done before, but this is the overall scenario moving forward. So the power of this, as you can see in this work that was done with human nuclei, is that we can sit down now and we can do the equivalent of thousands of surgeries in a controlled fashion, something you cannot do clinically. Too many variables. There's no really, we've eliminated everything other than the variable that we're looking at and we're doing it. And this first big study that we had that came out by the Mel, I think the most powerful thing that we found out that we didn't realize is how important parameters were. A lot of people always wanted to talk about what was the mode of phaco or ultrasound they were using. And if you look at the efficiency in regards to time, here is an example where we could go from 31 seconds to 5 seconds just based on the parameters. So if you don't know what your parameters are, I can show you anything is better than anything else. And you have to know what are optimal parameters before you compare it. So this was our first landmark study, and I think very powerful and opened, for us, opened our eyes as well, how critical parameters. We spent a lot of time trying to optimize those and understand it. The next step was, in as much surgery as Jeff does, he's so busy these days, he probably almost could have supplied it for us, but it's not that easy getting human nuclei from the third world. And so we needed to get another model. And so this particular group that we put together, we were working on a pig model, pig lenses we get plenty of, that were equivalent to these human lenses. So what did we do here? Same thing, here's your cubinator, putting it in place. We soaked them in balanced salt solution for 24 hours. This is the after formalin soak, different times, we'll talk about that. Then you cut it, and you mix it, and then you compare it. What did we find out? Well, the density test was really how much did it take to crush it to half of its overall size. And you can see, well, 2 hours looks like it's pretty close to these human nuclei. a pig available for. What about Kelman tip? Here's one that just shows me. I actually some of the people here were back when I gave the worst lecture. I love that, the worst lecture. When I first told Susan that I was asked to give the worst lecture, she said, "Well, you can do better than that." You know, Jan Verst is the Triple IC has one of their big lectures. And I talked about this. We have been taught by Charlie Kelman from time immemorial that the most way to do, efficient way to would actually doubles the time it takes to remove. Move a tip and it doubles the chatter. I see and question what's happening. All kinds of errors crop up and nobody knows about it. And another one I'll just talk about from the worst lecture. I love that. Anyway. And he had a standing pulse rate apparently like 42. He says, "You'll be dead before you turn 30. And Teddy Roosevelt famously said, "Sir, I'd rather die than put all my running around." Well, he was doing the right thing. What's an athlete's heart? It's not a super healthy person. So what finally changed that diagnosis and went forever? It was World War II. We had all these elite troops, paratroopers, etc. They were diagnosing them one after another with athlete's heart when somebody finally said, "We can't do this. We're eliminating our entire cadre of people and elite troops. Maybe it's okay." And it was really not World War II until finally this diagnosis died. I think we may have more athlete hearts out there than we realize. Tip diameter, again, big discussion going on. Real short, 0.9 seems to be the sweet spot. We've run into some smaller size tips that do quite well with interesting design, and then you're looking at other features. But as far as just a core regular round trip going on, that the combination of wanting to make sure that you totally seal to get vacuum, but you're losing efficiency by the size of the tube you're trying to ram it down. A 20 gauge seems to be the magic place. Micropulse, what are the best fluidic parameters associated with? A lot of interesting work. If you look at low flow, that it turns out it doesn't make any sense to go higher than 300 millimeters of mercury, because you don't get anything. Look at that. Why is it? Because it turns out that if your flow is only 20 milliliters a minute, you can't generate more than 300 millimeters of mercury. You can't pull enough to generate additional vacuum above that. Well, a lot of people didn't know that. You can see that it does make a difference when you start getting up at higher flow, because you can get that full vacuum realized and put in place. Again, new information, nice paper. Venturi. We know a lot about Venturi. A lot of people say it's better. Is it really? What is it? What happens with it? Indeed, as you can see, that 20 milliliters per minute, it consistently is 2 to 3 times better than peristaltic as far as its overall efficiency. Same time though is that if you look at this is looking at transverse, as far as chatter, Venturi dramatically better. You start getting up at 50 milliliters per minute. It makes a difference at lower vacuums, but by the time you get to high vacuum, they were statistically the same. But here's the big one. How much flow are you getting with Venturi? Remember, Venturi is vacuum-based. You don't control how much flow. It's inherent inside the system. Well, turns out your flow rate, when you're vacuum-based, is sitting up here at 70 to 100 milliliters per minute. Now, that's a lot. That's why a lot of people have been leery about how fast these go, so the price you pay. Turns out, from a physical standpoint, that if you were to take peristaltic flow to the same level, you should have the same overall effect. So you can gauge and judge, but no question that for most of what we do, Venturi is more efficient, but there's always a price. Here's one I love. Steve Dewey made a proposition that if you round the edge of the tip and you touch the capsule, are you more likely to break it? And so this is the regular tip. The idea is if you touch the capsule with ultrasound, you're going to break and tear it. If you round the tip and you touch it, you will not. Now that's something that we talked about for a long period of time. Wasn't good facts in association with it. So we started with some fresh human lenses. We took a look at it, and wow, looks like maybe there is something to this. Turns out that you've got one shot at a fresh human lens. Once you break the capsule, you can't do it anymore. But at least for the number we had, this is the number of taps to break. It took 4 versus 47. That was statistically significant. It's about a 10-fold difference. So again, we said, we need to come up with some way that we can duplicate these results without having to go through a human lens every time. That's not that easy to do. Solution? Saran wrap over a coffee can. High tech. And it works. We've got several good papers in association with that. We'll go on. This is a very busy slide. Don't get all the details, but the key thing I wanted to show you here is you looked at the sharp and dull. It was significantly better every step of the way. These comparisons were highly significant. Steve Dewey was right that it indeed is very protective of the capsule, often 5 to 10-fold less likely to break it. But is there a price to pay? As a person as an old physics major, I'm telling you, physics is a two-edged sword. You rarely get something for it. There's almost always a price you're going to pay. And so, again, very protective, as I mentioned. We published that in American Journal of Ophthalmology. We've now recently done a similar one, came out in HO in 2015, and we showed that in comparison to a linear approach, same energy, the transverse and torsional increased the capsule breakage rate. I think if you touch the capsule, you move it from side to side, that's easier to shear something than going straight in and out. And it was not a huge difference, but it was statistically significant. So what's the price? Well, we can decide and look at that. And you can see that if you're looking overall, say, at an Oslo type approach, torsional, that we about double the time. So when you're talking about pure torsional, yes, the Dewey chip is going to cut your efficiency roughly in half, and that was statistically significant. But if you're looking at a transversal, it wasn't. Those numbers are not only not statistically different, P of 0.9, I mean, those are the same. What about micropulse ultrasound? Those are the same. Now, when we first submitted this particular article in regards to this, using a radius tip versus non-radius tip, the questions that came back to us on this is, well, you just look at a really, really soft nuclei here. Is this really going to hold on something that's harder? These things probably don't work on harder. And so we said, fine, we can make harder. We can make them as hard as you want, how long they're going to soak in formalin. So we repeated it. There you are. Double the time again. Significant in regards to torsional. Transversal the same.
Can you comment on the difference between transversal and torsional?
So for those who don't know, torsional is the motion hundreds milliseconds, the net of that whole thing is there's an ellipsoid. Think of a football shape overall. Whereas linear, it's very simple. It's just going straight forward and back in each of these phases.
Difficult that there's not a good animal model for generation. There's never likely will be a good model.
Disease. And if you're going to look at human disease, let's get to the real source. So we currently have a repository now of somewhere over 7,500 pairs of eyes produced in an identical fashion. And you can see that one of the real messages here is it takes large numbers to do good science. So it sounds like a lot of eyes, but when I show you kind of the process we've gone through, it really is a lot. Patient cohorts, on the other hand, have been incredibly valuable as we've moved forward.
And we have access to about 70,000 to 80,000
samples currently in the Center for Translational Medicine. So those of you that are familiar with macular degeneration, I think you'll agree with this comment that there's a huge diversity of phenotypes, both for early stage disease, drusen, there's all kinds of drusen, and if you get to the histological level, you'll realize that there's even more phenotypes of drusen. And certainly you're familiar with lots of different forms of late stage disease, particularly neovascular disease. And I think we're starting to lose the plot here clinically in identifying some of these subtypes of neovascular disease, polypoidal, RAP lesions, choroidal, etc. But we thought one of the most important things we could contribute is asking the question, are there true genotype-phenotype associations in this disease? Okay, and so to get us to that point, became really important to understand the background genetics of the disease. In my particular group, we've been looking at genetics of macular degeneration for somewhere over 20 years now. But I want to leave you with an important message, and that is there are two major loci that are associated with risk for developing this disease in Caucasians, okay? One on chromosome 1, and that locus contains complement factor H and the factor H related genes, and a second major locus on chromosome 10 that contains a pair of genes, RH2 and HTRI1. Make the point again that over 95% of all risk is associated with these two loci. Okay, so it's really this gigantic gift. But I think on the scientific side, we've kind of whitewashed that a bit by wanting to go out and find more and more genes. And yes, there are a lot of minor gene associations, but if you're really going to dig into the disease and understand the pathways, you need to work on the two big ones. Put another way, clinically, if you look at my combined patient cohorts, only 5% of our AMD cases, grades 1B through 4C using the Rotterdam scale, only 5% of those cases don't carry any risk alleles at chromosome 1, chromosome 10, or C3. And I recently went through these 161 cases, and there's a lot of misdiagnosed AMD in those cases, Stargardt's disease, pseudoxanthoma, elasticum, et cetera, et cetera. And probably the remaining bit is associated with some of these minor gene associations. So the strategy we've used from day one is we knew we needed a really robust understanding of the genetics before we could do anything. Again, we're lucky, two major genes. Resources became critical, and this is the piece that the pharmaceutical industry just doesn't have access to. They don't have access to these human tissues. In fact, none of my colleagues in Europe have access to these kinds of tissues, and patient resources, and this has been really important. We can do lots and lots of good science, but without the knowledge of genetics and the resources, I don't think we'll ever get to this place where we're really finding true druggable targets for the disease. So just a little bit about the genetics. Chromosome 10, as I said, contains these two genes, ARMS2, HTRI1. It's been a real enigma as to which of those genes, or perhaps both of these genes, play a role in actually causing risk for the disease. This very interesting genetic block, strong linkage disequilibrium, but it becomes quite simple after you make it really complex. And there's a single variant, this A69S variant, tags all risk for this disease, at least in Caucasians again. and so that makes things a bit simpler. The chromosome 1 locus is a little bit rougher, 360 kilobases, contains complement factor H in a truncated isoform of factor H called truncated, and 5 of these so-called factor H related genes, numbered of course 1 through 5. If you look at haplotypes across this locus, a couple of really important points to leave you with. There are 2 major risk haplotypes, so not a single risk haplotype. More importantly, 2 major protective haplotypes, and those protective haplotypes are the most significantly associated haplotypes with AMD, but skewed towards the protection. And that's played very prominently in our thinking about developing therapeutics for this disease. In addition to things were tough enough, there's a neutral allele. So, and I'll leave you with one clinical thought. I think, if you're doing genotyping and you say, oh, my patient's carrying 1 risk allele of factor H, so he or she is at increased risk for developing the disease, it actually turns out that that's not true if this major risk allele is present with the second allele that's protection. So protection at this locus rules the day every time. So we spent a lot of time in Iowa looking for biological relationships between chromosome 1 and 10 biology, and we were never able to identify a direct biological interaction between those 2 pathways, and that has held true. We should have thought about this a long time ago. As I've gone around looking at patients in Africa and Asia and Easter Island, one striking observation is that Africans are mostly characterized by drusen. In fact, we've seen maybe 1 choroidal neovascular lesion that's due to AMD in our African cohort from Ghana. Asia, on the other hand, the disease is primarily neovascular, and very little in the way of drusen preceding disease development. And it turns out that the African genetics all skew towards chromosome 1, and the Asian genetics all skew towards chromosome 10. More recently, we've seen a lot of skewing towards chromosome 10 in the Native American population and others. So it turns out Caucasians are a mixture of the 2, and it makes for an interesting set of studies. But we thought at that time, wow, this is probably 2 very different diseases. And so we need to really dig in and look at what is chromosome 1 doing all by itself in the absence of 10 and the reverse. And so we've done a lot of that, and I don't have time to show you today, but we've addressed this at the ocular level, genetic, mechanistic, gene expression, it goes on, and systemically through blood biomarkers, through blood cell composition, co-segregating disease. And the message that I really want to leave you with today is that we strongly believe that macular degeneration is at least 2 major diseases. And it means that those diseases, that a lot of patients will carry both diseases. And here's one example, one of the early examples with genetics. If we reach into these cohorts that we have from Iowa, Melbourne, and Utah, and we look at the association of what I call pure chromosome 1, which are homozygous risk at 1 with no background risk at chromosome 10, and pure chromosome 10, risk at 10, no risk at 1. And you look at the association with AMD, you see that strong association of both genes. They're both driving geographic atrophy and choroidal neovascular disease. But the striking observation is chromosome 10 does not associate with early stage disease, and that means basically drusen. That doesn't associate with drusen formation. And if you dig in clinically and start pulling out these groups, these pure chromosome 1s and 10s, you'll find that the chromosome 1 group is driven by the formation of drusen. Drusen are much less prominent in the chromosome 10s, and you can see a lot of other clinical features that are different between the 2. There's this obvious optic nerve issue that skews with chromosome 10. We've been chasing that a long time. And there's a whole plethora of differences between chromosome 1 patients and chromosome 10 patients. I'm going to go through those very quickly since most of the audience is clinical. But if you just look, of course, this drusen observation comes screaming out. Chromosome 1 patients are strongly associated with the development of large macular AREDS grade 3 drusen in the macula, pigment epithelial detachments. 55% of our chromosome 1 patients over the age of 60 show this phenotype, in contrast to about 8% of our chromosome 10 patients. Histologically, you can see here's a donor that had large soft macular drusen. You can see the phenotype very nicely. Again, chromosome 1 very much characterized by these sub-RPE deposits, pigmented epithelial detachments. And interestingly, in the donor eyes, very often the separation between the RPE and the gross membrane, which I think is important from a biological mechanism. Chromosome 10 patients, very little in the way of drusen. You can see there's a little drusen. They tend to have these cuticular drusen that don't move or change shape with aging. And the retinas, I think you all appreciate if you look at these en masse like this, the retinas seem thinner than the chromosome 1 patients. Chromosome 10 patients histologically, if they do separate, they separate between the retina and the RPE, so very different separation. Phil Luthert, a very good pathologist from Moorfields, was here the last few weeks looking at this. He said, these look dodgy. And remember, they're all fixed in the same period of time, so we're working hard to quantify what the differences are. But one interesting clinical observation is the chromosome 10 retinas are thinner across the board, beginning from an age about 40 or 50 years of age. The retinal and choroidal vasculature is far less dense in the chromosome 10s than it is in the 1s. You can see that here. On average, about 30 to 40% lower vascular density. We thought we could really dig into this heavily with OCT angiography, and it's just not quite there yet, so we'll have to continue to do it the hard way. Fluid distribution and neovascular phenotype are very different in the chromosome 1s and 10s. The chromosome 1 patients strongly characterized by the accumulation of subretinal, sub-RPE fluid, in comparison to the chromosome 10 patients characterized primarily by intraretinal fluid. Phenotype, you can see this was grading that was done. I think Al's sitting in the back. Al helped us a lot with this early on. Chromosome 10 patients very much skewed towards a classification of classic CNV as compared to chromosome 1s, which are graded primarily as classics, probably speaking to the type of neovascularization. And we think that 10 is largely associated with RAC lesions, and have certainly shown that to be true in the Japanese cohort. The response to anti-VEGF agents varies dramatically between the chromosome 1 and 10 patients. Basically, your patients that take injection after injection and kind of maintain vision are your chromosome 1 patients. I don't have a lot of time to talk about the biology, but the biological manifestations of these two diseases also differ dramatically. We've seen incredible associations of histological features with 1 and 10. Basal laminar deposits, for example, strongly driven by chromosome 10 as compared to chromosome 1. Serum biomarkers, blood composition are dramatically different in the two groups. And I'm going to show you one example, gene expression, which is really getting down to the nitty-gritty of what pathways are chromosomes 1 and 10 driving. And we've been very fortunate, this relationship with Allergan, the one thing that it did do is it gave us the opportunity to run this huge gene expression study. And basically, without going into details, we used 7 pure genotype groups with about 50 donors and 50 patients per group, 1,400 total samples. And this platform, this particular platform we used was called the Diaxon HIT platform. 6 million probes for 23,000 genes, and we generated about 8 billion data points. But more than any other experiment, this has really started to teach us about pathways that are driven specifically by 1 and 10. There's no good way to show that, of course, so this is real data. And you can see that there are dramatic differences in gene expression profiles between 1s and 10s. And we looked at macula, extramacula, RPE, choroid, and retina. So 4 pieces of tissue for each donor. What we have learned, we've learned a ton about ocular sites of gene expression. And that becomes particularly important on chromosome 1. Where is complement factor H actually being made? And we've had some surprises on that front. We've learned a ton about biological mechanisms, and then we've been able to use the data to go back into the SAMIs and show that yes, indeed, those mechanisms truly are active. And we've learned a lot about potential targets for drug development. So I'll give you one example. The complement system is, of course, comprised of about 85, 90 different proteins. And for the first time, we have a very robust understanding of what's happening in the back of the eye with the complement system. And that becomes very important when you start thinking about, is factor D antibody treatment really the right way to go? Do we have any data whatsoever that factor D is upregulated or downregulated in the back of the eye and that we need to inhibit it? And that story goes on. We've had a lot of surprises here. And we've been able to take that gene expression data and combine it with RNA sequence data and functional data and protein distribution data, et cetera, and really show that the pathways that we think are good candidates for drug development truly are that. And I'll leave you with the message that really these are just examples of haplotypes across that chromosome 1 locus and their association with the presence or absence of macular degeneration. No AMD being the brown bar, AMD being the blue bar. And you can certainly see in the case of chromosome 1, our therapies need to mimic this highly protective haplotype in the form of the disease. I think we would have probably had drug in patients sometime in 2017 if we would have been able to maintain the Allergan relationship, but we are ready to treat chromosome 1, and we're ready to do it in the right patients. Chromosome 10, I would have stood up 6 months ago and said, it's a difficult locus, we're not making much progress, but the team has really made some important discoveries. And I think this very complicated locus that I described early, we are now at a place where we think we have really found a region of frank causality within that locus. And that knowledge is really quickly pointing us to the mechanisms that are active in chromosome 10 disease. And hopefully next year I'll really be able to tell you the end of the story. So I'm going to leave you with a few messages. Hopefully the message that all of you will take home is that AMD is very, very likely 2 distinct biological diseases. Do these minor genes play a role? Probably, modulating to some degree, but we've looked at that a lot using the same strategies, and we don't see a lot of these actually being causal for macular degeneration. We've learned a lot about the underpinning biology of both chromosome 1 and 10 directed disease. We've identified critical pathways, mechanisms, and targets. We're really at the place where I think on chromosome 1, we're ready for developing treatments. Chromosome 10 a little farther behind. And I hate seeing this situation out there where I think potentially good drugs are failing trials because of lack of this knowledge. And so certainly one thing we will do here at the Moran is group our patients appropriately for trials. I envision the first trial with the chromosome 1 directed drug to be directed towards chromosome 1 patients, not with the chromosome 10 in the background, right? 2 very different pathways, and I think it's obvious why some complement inhibitors have failed in trials because they have a huge amount of chromosome 10 in the background. So let's not lose potentially effective drugs for the wrong reasons. So with that, I'll stop. Happy to take any questions.
Great. So, fantastic. I've loved following it so long, but here's a chance for me to talk to all the clinicians here in the room. This is an example where we very much would be involved. He's got a group ready, prepared to look at patients, but who's seeing the patients? We are. And the group that they need to look at, they want to look at people with macular degeneration. The more we can get, the more robust. And it's hard to look at them and to differentiate, but that can be done. Also interested in people who are younger with a family history of macular degeneration. And frankly, probably one of the shortages are people who are older who really don't have any changes in the retina at all. Those people over 70 or 80, you know, you see them, they don't have any drusen or anything, but what I like to call it super normal. And if you're not sure, that's fine, but if I found all you need to do is you just say, listen, we're really working hard on macular degeneration, and often these people either have a family history or they're older, they know people, and say, could you give us a few minutes? You let your clinic coordinator, they'll talk to Jill and her team, everything else is taken care of, it doesn't take very long, I've never had a complaint about it, but all of us seeing patients here can help dramatically, expanding those cohorts to help us to where we can further understand this disease. And remember, the future treatment is going to be pure ones, pure tens, and there's no place in the country that has large groups of these, and we have large groups, we need larger. So just a shout out in regards to that. All of us can be involved in this, and I think it's going to be really important. We announced this major partner, it's to hit the ground running. We want to move this into new core treatments, getting at the basis of the disease.
Thanks, Randy, I appreciate that. I also want to, it was a little bit remiss not thanking those of you that are out in index. As you know, in the last month, a new index has been approved, which is called Raindrop. Last year, camera index was approved. So we know that these index are coming down the pike, and we want to know if we can offer them to our patients. I would like to acknowledge my colleagues who have helped me throughout this last 6 months working on this project. And I do not have any financial interest in any of the products that are mentioned here, any of the lasers. And I also want you to know that most of my co-authors also don't have any financial interest, except Dr. Derry, who does have stock in the AcuFocus. AcuFocus is a small aperture corneal inlay, which is 3.8 millimeter on the outside diameter and 1.6 in the central pinhole area. The size of it is almost the size of a red blood cell, which is about 5 microns. And the material is very similar to the material that you see in the haptics of your 3-piece lenses. The concept is very simple to the concept of pinhole effect. It simply increases your depth of field. It doesn't have a power. It doesn't have a 1 diopter add or 2 diopter add. It simply uses the pinhole concept that we're all familiar with in order to increase the depth of field. Theoretically, it should not impact your distance vision. And this is a good demonstration of that. How we can increase the depth of field by using the pinhole effect. The way it's inserted is with the assistance of a femtosecond machine. It creates a pocket, not a flap. You create a pocket along certain meridian, and then you insert this with your special inserting device. The FDA approved this technology in 2015.
2015 in April, based on 6-year result, primarily on the safety issues. The labeling is primarily for patients who are between 45 and 60, and these patients need to be ametropic. That means they shouldn't be wearing any glasses for distance. They should be in the ranges of 2025 to 2015, and they should be basically dependent on reading glasses. Now, let's face it, in our refractive world, most of the patients will knock on our doors and ask for vision correction surgery. It's hard to find somebody who's purely ametropic with a very small refractive error. Many of our patients can have 1 or 2 diopters of refractive error. In terms of sphere, they may have some stigmatism, which is more than 0.75 diopters. So when the patient comes to us and they ask us with enthusiasm for inlays of some form, and we have to tell them that you are not in this window of population, what can we do for them? And this is where a lot of the European authors have looked and say, well, can we emmetropize these patients? Can we take their myopia down? Can we reduce their stigmatism to this level, bring them to this sort of refractive error, and then put the inlay in their eyes? When I looked at the data that has been provided to us by the FDA, and you look at the bar graph, it shows that 91.9%, 92% of the patients who were slightly myopic, that means there were patients between minus 0.75 and 0. These patients did a lot better when it came to near visual acuity, compared to the other bar, which is 76% for patients who are slightly hyperopic. So when it comes to the camera inlay specifically, I personally think it works better on patients who are slightly myopic. But when it comes to range drop, if anything, it's better for the patients who are slightly hyperopic. And based on this, and based on a lot of the European experience, many of us who are interested to use inlays in our presbyopic population lean toward the camera pinhole aperture inlays for patients who are slightly myopic. And this is nicely shown here. So how does this help us? This helps us to understand that if you have a patient who is -8 or -4 and has 2 or 3 diopters of stigmatism, and if you're trying to bring this patient to a level that can benefit from the camera inlay, bring their non-dominant eye and leave them approximately -0.5 to -0.75 myopic in their non-dominant eye, and many of these patients could be 57, 58 years old, and then implant the camera inlay in them, either consecutively or simultaneously. This is a defocus curve, which is simply showing that if you shift the defocus from plano to -0.75, it can actually increase the amplitude of the patient's capability of seeing by 2.75 diopters in terms of depth of focus. So the 2 questions that many of us have is, can we combine this? Can we mishmash it? And is it going to be safe? And should we do PRK or should we do LASIK? Which one is better? And this is simply a preliminary result based on about 42 to 45 patients in each arm of the study that I've had for the 3 months and 6 months. The 6 months data actually has an attrition and goes to less than 10 patients in the LASIK arm and about 36 patients in the PRK arm. But before I go there, I think that it's important to talk about centration. Centration has always been a challenge in refractive surgery. From the time that Dr. Casebeer was teaching us the RKs, and from the time that we went to use excimer lasers, and this first generation excimer lasers, where we didn't have eye tracker, we really don't know where is the right place to place the ablation, or where was the right place to put the RK incision. Is it the Purkinje reflex 1? Is it the center of the pupil? And this dilemma has been with us, but when it came to eye trackers, we simply learned that we should just focus on the pupillary aperture, and we should simply ablate with respect to the pupillary aperture. And even now that we have gotten sophisticated with the femtosecond assisted cataract surgery, and we see all these multifocal lenses, many of us have learned that when it comes to large angle kappa, sometimes between 0.5 and 0.7, the multifocal lenses, if they are not placed with respect to the angle kappa and the Purkinje reflex 1, you may not have a good result. So now we're realizing that centration is becoming even bigger issue than ever before, and that also applies to hyperopic LASIK with large angle kappa. So when it comes to the camera inlay, where are we going to put it? Are we going to put it with respect to the pupil? Are we going to put it with respect to the Purkinje reflex 1? And it's been shown that there are some studies that it is better if you actually place this with respect to the Purkinje reflex. One, but many of us that still feel uncomfortable to do that try to center this thing somewhere between the pupil as well as the Purkinje. Goes back to intact and hyperopic LASIK, the same concept applies. Centration is primarily done somewhere between those two spots. And there are different techniques for that. There are different diagnostic devices. Many people have an OPD scan, skioscopy. Some people have a ray tracing technique by Sharing's principle. So you can use these machines in the practices, and I don't have any financial interest in any one of these things, but you can use this in order to see where the angle kappa is, and where is the entrance pupil, and where is the reflex. And by using that, you can actually have the data in a snapshot, take it to the operating room, and use it for your multifocal, use it for your camera inlay, your presbyterian inlay, etc., etc. And this is a good example of topography guided centration with a Vario, and it actually shows you both mesopic and photopic and also the Purkinje reflex. So this is another device that people use, which is called the AccuTarget. Again, another device that helps us to have a numerical understanding of where the center of the pupil will be with respect to, this is the center of that, and this is the center of the pupil. And this, in this area, we're lucky because these two are very close. But if somebody had a more nasal angle kappa, the Purkinje reflex would have been here, and then the center of the pupil entrance is here, and where would you put that? And it is recommended that it should be between them. And the beauty of such multitude of diagnostic devices is, for example, AccuTarget or the others, when you put the camera in there, later on you can go back and you can actually see how off you are with respect to the pupil and how off you are with respect to the Purkinje and where it becomes significant. And again, you can take a snapshot of these, take it to the operating room, whether you sit temporally and superiorly, you can use this for your multifocal implantation, your inlay, whatever. I like the Mastel ring personally myself. It's a very simple device. You don't need a huge diagnostic machine, an expensive one, but it gives you a fixation point that you can use throughout the procedure, and patient can fixate on that and can give you an idea in terms of your centration. There are machines, the eczema laser that some people use in order to tell them where the center of the site is. This is another one when the patient is looking in there, they are fixating. This is the Visex laser. We can use what we have at hand in order to help us in terms of centration. I simply want to show that what we're doing here is I am placing some ink mark, trying to have where the limbus is, so that when I put the femtosecond on, I know exactly where the limbus is, because you want the incision to be as temporal as possible so you do not induce astigmatism, and then the centration is done with a heavy mark, because you do want this heavy mark to be on the right place for the duration of your surgery, so it doesn't dissipate, so you know exactly where it is. There are 3 different platforms that can create pockets for the inlay insertions. And this one is the most common one used by the Interlace or AMO company has it. Again, it creates the pocket for us. The other one is the FS200. FS200 has the capability of creating your pocket at 180 meridian, 90 meridian, 75 meridian. And the beauty of that is that if somebody has 0.75 or 1 diopters of astigmatism, you can actually place the FS200 along the meridian that you like. So that's one advantage for the Alcon FS200 femtosecond, because it gives you the ability to create your pocket in whichever meridian you want, and that can also help with astigmatism as well. Insertion, again, you do have your heavy mark from before, hopefully it hasn't dissipated, and then you simply place your inlay. And the reason here you cannot rely on the patient is because at this point the vision is quite distorted, the patient cannot see. That's why the original centration becomes critical. So in my study design, we had one group that had the PRK and the inlay at the same time. in their non-dominant eye, aiming for minus 0.75 diopter. And in the group 2, they had LASIK and the inlay in their non-dominant eye, aiming for minus 0.75 refractive error with the LASIK part of it. Their dominant eye, of course, got LASIK or PRK accordingly. 44 patients in each arm and 45 in the other, and 10 patients in my LASIK group, 6 months follow-up, and 42 in the 6 months follow-up for the PRK. Demographically, these patients overall are very similar preoperatively in terms of cylinder and the myopia or hyperopia. And in terms of PRK technique, very simple centration. You create a pocket, you insert your inlay, and then you go to your laser and you do your PRK. And I'll try to show that here. This video has been already on an iTube website under the inlay section. The centration is done based on the information you gathered preoperatively, based on whatever diagnostic device you prefer. The pocket is being created using whatever femtosecond modality you like to have. The pocket size is approximately 4.7 because you need to have enough wiggle room in order to place this, because if you don't, then you won't be able to center it. After the placement of the inlay, patient is being taken to the excimer. We do not place this underneath the excimer laser. We use the microscope, the surgical microscope that you use for your cataract or your other procedure. We think the view is so much better in order to place the inlay and have the fixation. So after the inlay is placed, you have to actually physically move the patient to the excimer laser so that you can use that optics for your PRK treatment, aiming for your undercorrection of 0.75 diopters. The 20% ethanol is used here in order to remove the epithelium, and then subsequently the ablation is being applied. The challenges that we have when you are doing simultaneous surgery, especially in the beginning, is if for any reason your XY coordinate of your camera inlay implantation is not perfectly centered with respect to the Purkinje or the pupil, your ablation is going to be decentered. So if I was not careful and I did not put this in the right place, the eye tracker is not going to track the pupil. The eye tracker is going to actually track this inlay. So you can see that the ablation can become decentered if you don't know where to put the inlay. That is why many people advocate you do the PRK, you aim for minus 0.75 diopters, you come back 3 months later and you put the inlay. Because you don't want to put a decentered inlay and have the ablation also decentered. That can be very problematic. And this is where some people believe it is better to do them consecutively, first the ablation pattern done, and then 3 months later the inlay. And we do have a small subgroup of that, and I like to see once the data is available to know whether consecutive is better than simultaneous. The rest of the procedure is very similar. In terms of the corticosteroid treatment, I will briefly talk about that momentarily after we finish with the LASIK part of the procedure. When it comes to the LASIK part, initially we all thought, well, that's not a problem. We create our LASIK flap, we do our LASIK, and then we put the inlay and we close the flap. Why we don't even need to have a pocket? Well, studies after studies has shown over time that if you do that, you actually cause hyperopic shift because the flaps are only 100 microns or 125 microns, whereas the pockets are usually placed at 200 or 250 microns. If we place these pockets, these inlets underneath the flap that we usually do for LASIK, you will have suboptimal result and you create huge hyperopic shift over the course of time. This is the way that has been described in Europe and many places to do, and it's quite simple. You lift the flap, you do your ablation, and then there you go, you put that at the same time. But this has been abandoned over time because it has been taught that this is not the right way to do, looking at the literature from Asia as well as Europe. So we are now placing the pockets deeper as long as the residual stromal bed is more than 250 micron, and then the pocket is at that depth. Then you actually go back and you make your flap either simultaneously or consecutively at a different time. Here, this is the technique that has been described by others, and we don't advocate this, but I would like to show you. This is a good colleague of ours who does simultaneously flag creation and pocket creation within a matter of a minute with their femtosecond device, places the camera inlay underneath that 250 micron pocket, then lifts the flap, does the treatment underneath the 100 micron flap. So there's only 100 micron of space between the two lamellae, two planes, and places the treatment over the camera. The problem I have with this technique, and we did this on some cadaver eyes, is the bed is not regular. If you create two cuts, one after the other. And also, again, the challenge is, what if your centration of the inlay is not proper? Your ablation is also going to be decentered, because that's all the machine understands. Although they have shown some good results with that, we believe that it should be done differently. First, the pocket is created. Then we wait a good 5 to 10 minutes to make sure all the bubbles are gone, whether they are OBLs or not. Then we go to the contralateral eye. We make the flap in the contralateral eye. We come back to the eye of interest, almost 10-15 minutes later, and then you make your lamellar cut. Now I'm hoping that this will come with time. This was the, I think it's, I cannot see it here, but we'll figure it out. It's okay. Maybe it's here. We'll see. It usually takes a few seconds. And for some reason, it's not doing it. But if I get it, I'll show it to you guys. Going back to this and coming back to it. So I'll try to see if I can have that shown. But getting back to the results, if you look at the FDA result, and this is the communication that people lack to do for when they're talking with the presbyopia patients. When you look at the FDA result for the camera inlay, 91 to 92% of the patients achieve visual acuity of 20/40 for near, or some people call it J5. Binocularly, most of the time with both eyes open. In terms of J2 or better, which is 20/25 or better, only about 50 to 60% achieve that. And that's the communication that as a surgeon you need to have with your patient. Because when you look at the data that FDA has provided, that is the reality of it. That 91 to 92% of the patients see J5, which is 20/40, and about 50 to 60 see J2. And if you communicate with the patients that and explain to them, this is the outcome, some patients may say, well, I don't want this, this is not what I was expecting. So that's why if you go with that standard, and that's the FDA labeling, the results that we got for both of our groups, whether it was for distance or near, is quite comparable to what the FDA has right now for the emmetropic patients. And we showed that, of course, the LASIK patients always start better than the PRK patients, but then they eventually reach almost the same endpoint, even though we had 10 patients in the LASIK and about 36 patients for the PRK, but here they were more comparable. And that is the binocular uncorrected near vision. That means both eyes open, looking through the inlay and non-dominant eye. And this is the monocular distance vision, and it shows that the distance vision is not compromised at the end. A majority of these patients still in their non-dominant eye and still maintain a good distance vision despite the fact that they have an inlay that helps them with their near. In terms of safety, none of our patients lost 2 lines of vision. And as you know, FDA says 5% or less can lose 2 lines of best corrected vision. 11% of our patients lost 1 line of corrected distance vision, and that is still within what they call FDA parameters. 58% saw J2, and 89% saw 20/40, or what people call J5. And when we look at the LASIK camera group, again, 91% saw 20/40 at near, 62% saw 20/25 at near. And in terms of safety, again, nobody lost 2 lines or more, but there were 12% that lost 1 line of potential vision in that eye. That means if they were 20/20, now they're 20/25, or if they were 20/15, now they're 20/20. In my opinion, as long as this communication takes place, there are some patients that can have the surgery done. The concept of doing them simultaneously, if somebody's experienced, maybe they can do it, but consecutive within 3 months of one another is a very justifiable way of approaching this. PRK is always slow in healing, but that's the case whether if you're doing a pure PRK or you're doing PRK with another modality. So whether you're doing PRK camera or LASIK camera, the healing time is still the same. That does not change. I thank you for your attention.
Questions for Dr. Moshe?
Did you always have the camera at the same exact depth for all your PRK and all your LASIK patients, or did you adjust it?
Of course, it has to be adjusted. The question is, what about the depth of the camera? You have to understand if you have somebody who's -8 diopters, and the patient has 550 micron cornea, and you create a flap of 100 micron for the flap part and do that -8 diopters. -8 diopters is almost going to be another 96 to 100 micron. So if you have 100 micron, another 100 micron. So you really need to put your inlay at a depth of 340 micron. That is beyond the 250 micron reserve. So if somebody is -8 and they want to get camera, and even if their cornea is 550 micron, you cannot do it with the LASIK. You have to do it with PRK. On the other hand, if somebody is 550 micron and they're -4 diopters, you can do it. So you have to respect the residual stromal bed. Based on the level of myopia, there are some patients that if they want to get their inlay, it has to be done with PRK, not LASIK.
Gee, fascinating as always. You always present some great material. It would seem to me that just trying to kind of the physics of this, that there's, like I said, there's almost always a downside. Do these people notice that potentially their mesopic vision isn't quite as good? You are blocking a certain amount of that paracentral light in order to get the pinhole effect. Or is this really subclinical? You really don't see patients noticing that there is a difference in that lower line situation.
In order to answer that question, I will just say something. We've been all in this business long enough to see Hyperion, LTK came by, CK came by, Intax came by for many things, and many of them are gone and dead. And let's look at it. Hyperion, LTK is not here anymore. CK is here, but we use it for a different thing. We're using it for what? We're using it for keratoconus patients. Intact, we're not using it for myopes anymore, we're using it. So I use that disclaimer to say that here I am discussing camera inlay, not to say that camera inlay is the best thing after the discovery of other things. The answer to your question is definitely it affects it. As a matter of fact, that eye is dimmer, so if something goes by, they can actually get an effect from that. So my opinion is that if somebody says less photons are getting through that area, absolutely, and I think there is diminution of quality of vision in mesopic, and then of course we will know, and they know that they show you the contrast sensitivity binocularly, and there is no impact. But if you monocularly look at it, there is definitely diminution. Contrast sensitivity not only in mesopic but also in photopic environment. But the thing is, the camera inlay, despite all of the stuff that it has, and despite the fact that it can affect the night vision, for some patients who have learned to have a suppressed image for whatever monovision they had in the past, it doesn't bother them as much. With regard to the distance vision, I was surprised to see that many of these patients, unlike the monovision when we do monovision, patients go in their non-dominant eye to 20/40, 20/50, or 20/60. These patients still maintain that 20/25, 20/30, even though they have their J2, J3 range. Majority of my patients are J4 and J3s. There are some that are J1 and J2, maybe because they're younger and they have some accommodation reserve. But as I said, this is the technology for people who want to have their Saturday morning vision for reading their paper. This is not for somebody who wants to sit down and read the War and Peace novel. But as to
down and speak as one of our clinical faculty members. He now has a very busy private practice at the Black Hills Center there in Rapid City, South Dakota, and he's going to talk to us a little bit about co-managing cataract surgery patients. Back to you, sir.
Well, I'm very grateful to be back here where I trained, actually not in this building, but in the old Moran building. It's really great to see old friends and people who are helpful and responsible for me having a fun and successful career. So it's nice to be able to come back and try information back. And this is the information that I never got as a resident because there's really no, in residency you don't get involved in billing and certainly not in co-managing. It's really not a thing that's necessary here, but where I am it is. So when I told Nick I could give this back in like February or March or so was still clinical faculty day. I don't have any research to translate for you, so sorry about that. I'm not paid, I don't have any interest, and I'm going to talk.
That's a financial disclosure.
Yes, that is it. So I'm right off this trip to come out here and see my son and give a lecture. But it is true, we get out there in private practices and away from academic centers that optometrists and ophthalmologists do have to work together. And I'll show you why in a moment. But co-management is a relationship where the surgeon can do the case and the patient's regular eye doctor can see them and take care of their follow-up care. The surgeon is ultimately responsible for anybody that has a surgery, but they can share care and follow. That's different than a transfer of care, which is when a different circumstance, say somebody's referred over to another person, you no longer have responsibility. In co-managing, the surgeon does have responsibility. And there are a lot of optometrists that are out there that want to co-manage their patients. There's different reasons, and there's even some controversy about that in the medical world. But there are situations where it is totally appropriate for cataract surgery patients. So what I wanted to do is tell you how you do it, what is ethical, what are the rules, and how to bill for it. So I live in the Black Hills, which is this little hilly mountainous area in the middle of a great big area of plains. And this little symbol represents there in our town in Rapid City, we have ophthalmologists and optometrists. And the next closest ophthalmologists are like 250 miles in any direction. So there is a lot of space out there where there's just optometrists. It's a little different than the setting you guys have right here in this valley. But what happens when a patient in Eagle Butte needs cataract surgery, or a patient in the middle of nowhere that drives, these people literally drive a couple of hours just for their appointment. So this is an indication where co-managing is a situation that can be helpful and is in the patient's best interest. They all want to come to Black Hills anyway because it's so beautiful. This is a picture I took in the Black Hills, 25 miles from my house, where you can drive through tunnels and look right at Mount Rushmore. And so in Rapid City has 11 ophthalmologists, and it's only a population of 70,000, but they're all way more busy than what you would expect in normally, I think they say 20,000 population for each ophthalmologist. So let's talk a little bit about the co-managing. In my practice, the patients have been going to their optometrist for all their routine care for a long time, and then those are the ones who typically diagnose them. I don't have a practice full of people who come to me for routine care. I don't even do, my practice is so busy with medical and surgical problems, I don't even do contacts and glasses. It's not part of what, you have to be efficient. And so we have to divide and conquer these tasks. So the optometrist is deciding when that rancher needs to come in and have their surgery. And, the treatment for their cataract initially might be observation, or it might be some guy comes in off the farm, hasn't seen a doctor for 10 years, whatever the situation might be, but they decide when a cataract is advanced enough to refer. It's the ophthalmologist who makes the decision for surgery. So when a patient is referred, it's for an evaluation. And that comes from the recently updated ASCRS position paper that the ophthalmologist is responsible for all surgical care, including post-op care, and that starts with the determination of the need for surgery. So I'll show you a sample of what I'm talking about here. A woman might be referred by her optometrist for cataracts. She comes in with, you see the referral note, maybe 2+ nuclear sclerosis. Vision might be not 20/20. And she complains that my vision gets blurry after reading for a while. And otherwise, I see just fine. And so in this case, it might not be that you need to treat what she was referred for. During your normal evaluations, you're going to find out what their complaints are, what are their effects on their daily visual activities. But in someone like that, that cataracts don't cause vision to fluctuate the way that the dry eyes do. And you saw from that little picture that she had dry eye syndrome. So here's a patient that was referred for a cataract surgery that ends up being treated for dry eyes. And in a situation like that, you might recommend some treatments, maybe send a letter back. We might, some optometrists like to do plugs or put people on meds. Sometimes you end up doing that. You might follow up on the patient or have the optometrist see them back. But not every patient that is referred for cataracts can or does necessarily need cataract surgery. And so I've had many patients that get sent back. And what we do is we give lectures to the optometrists once a year so they kind of know. When you work with the optometrist routinely, you know which ones kind of know what to do, and you can teach them. And so they don't take it personally, but when you have a patient like that, it's easier to have everyone happy in the long run when you treat them right and when they have real cataract complaints. Another picture in the Black Hills, I always thought this was cool. They have this highway where there's these little pigtails that they kind of wrap around in order to get up the hills. Last month, they had, the usual Sturgis rally where there's 500,000 people on their Harleys that come to right there. Fun place to come in August if you want to like people watching. So when is surgical treatment indicated? I adapted this talk from a talk that I give to optometrists, but most of the medical stuff has been taken out of this talk, except I left this slide in, just because you should know when cataract surgery is indicated, and it's based on visual function, or lens-induced diseases like phakomorphic glaucoma, or it's necessary to visualize the fungus in an eye that otherwise still has visual potential. But my optometrist thinks I need a multifocal IOL is not an indication for surgery. If patients can see well with their glasses or contacts and their activities of daily living are not affected, then they don't necessarily need surgery. And surgery won't improve visual function. The asterisk there is because there are some other situations like the phakomorphic glaucoma type stuff. If they can't undergo surgery because of coexisting medical conditions, and if appropriate postoperative care can't be obtained. So if there are patients who say, you know what, I'm going to be out in the middle of nowhere on my ranch and I'm not going to come in for follow-ups, they don't get surgery. Some Medicare carriers require more specific when it comes to reduced visual acuity and such. So we have to follow those guidelines as well. And inducement for surgical referrals, coercion by a referring practitioner are not factors that should influence your decision to do cataract surgery. You know, the optometrist who wants to go out and find which doctor is going to pay him the most money, the surgeons who want to give gifts or kickbacks, that's not allowable. That's not why co-managing is done. When an optometrist refers a patient, they need to inform that patient that the ophthalmologist is going to see them in clinic. So many people come in and think, okay, I'm having my surgery today, right? And no, sorry, you're not having it today. And they might discuss options. Optometrists might know that a patient has used multifocal contact lenses, for example, or they have used contact lenses for monovision. And when they refer patients, that's the kind of information that needs to be communicated back and forth. The options for expensive premium lenses or upgrades should not be a factor on who they refer patients to. Optometrists know the patient. So when an OD sends me a referral note and says, call me, and I call him up and he says, man, this is the guy who is the engineer type that is always complaining. He comes back, every year he comes back, his glasses aren't right. This guy can never please, never make happy. That's another important piece of information because that might help you decide if this patient is a candidate for something like an upgrade option. The ophthalmologist in a co-managing situation is responsible for the consent, the plan, the options, the expectations, and to inform the patient or discuss the options for co-managing post-operative care arrangements. Co-management cannot be done as a matter of routine policy on all patients. It's unethical to share the care for economic reasons. Patients have to consent. They have to sign a form that says that they understand what the arrangement is and that they have access back to the surgeon if needed. And there's no fixed time. You can't have a policy that says, I always am going to see the one-day follow-up and my optometrist is always going to see the one-week follow-up. You have to wait and see what the patients look like and make sure that they're in a stable condition to go back. The patient has to have access to the surgeon. Now, when they're seeing somebody way off in the middle of nowhere and the optometrist is there can be situations where maybe they can't get back right away. If you've got a patient that's a far ways away and has some kind of post-operative problem, you really have to have a way to perhaps travel is arranged, things like that. I've seen cases where an optometrist tried to lower the eye pressure, and instead of trying to make a little tap on that small paracentesis incision, they pushed on the big temporal clear corneal incision until the iris came out, and then you got another surgery coming up. So you want to make sure you communicate and educate your optometrist in co-managing situations. And it should not be done against the patient's interest. It's not done because it helps the optometrist and it helps the ophthalmologist get more referrals from that optometrist. So let's talk about what that's worth. The value of the post-operative care is 20%. Now that doesn't make sense. It's 20% of the global package, which includes the surgery and the post-operative care. When you're talking about Medicare, if you're doing a cataract surgery and you're co-managing the surgery portion that you bill for, it's this modifier 54, and automatically the surgeon gets only 80% of that surgeon fee. And the 20% is shared between the ophthalmologist and the optometrist. If an optometrist sees all of the post-op care, they would get that entire 20%. So here's an example case. Cataract surgery on May 1st, the surgeon bills with the modifier fee 54 for the surgery, and Medicare gives them 80% of the total global fee. The rest of it is going to be divided up. So for the post-operative care, the surgeon who sees them will be billing that patient for a portion of that 20%. So if the optometrist takes over care on May 12th, which is 10 days after the surgery, they bill for 80 out of 90 of the days. And so that 20%, the optometrist will collect whatever percentage that is. You have to follow proper Medicare billing guidelines and use the appropriate codes, and I think most of the private insurances follow the same rules. And if your surgery code is upgraded to a complex surgery, you have to let the optometrist know because they have to bill their co-managing post-op under that same coding. Medicare requirements do not apply to the refractive or upgrade portions. So there's lots of different ways that this might be done, and to tell you the truth, I don't know what is lawful in the situation, but what we do is try to make it so if there's an upgrade cost on a patient, then the OD can actually get part of that cost, but it has to be at a fair market value. For example, if they're billing for a total of 10% of the follow-up care, then 10% of that upgrade fee might be something that seems as a fair market value as well. So when it comes to the premium lenses, I think optometrists are very helpful. Like I was saying, they know the patient. They're happy to see him back. They're excited to see new technologies, but they should be familiar with the options, and they should not get kickbacks. And like I said before, I think there are places where the surgeons kind of require or incentivize ODs with premium IOLs, and that's not ethical. Communication is really important. You know, pick up the phone, call your optometrist you're working with. If it's somebody new or you haven't worked with them before, make sure you find out if they're comfortable with that. Have they done an optometry fellowship where they've seen post-operative care, or have they been in a situation where they see a lot of that? If not, you might invite them to come and watch surgery so they know exactly what's going on. I've had a lot of optometrists come into the operating room and watch cases with me. Make sure you send notes back and forth, especially if there's anything unusual. If a patient had a high follow-up intraocular pressure and you added an aqueous suppressant drop to their post-op regimen, and they're in a situation where they're maybe following up next time with the optometrist, make sure they know what your plan is, what pressure expectations are, and what to do with the drops. And that's it. So I'm happy happy to take any questions. A little bit different, but I thought you guys might enjoy seeing something that comes out from a private practice perspective. I do some research too, but like what I do is those kind of FDA trials where there's multi-center things and they need sites to do cases for a phase 3 approval. But sorry, again, nothing to translate. Brad?
Terry, I think, especially in a place like Rapid City where, like you said, access to care is so difficult for people that live out in the sticks, this model is really effective. And I think the fact that you also combine the education piece by giving lectures for the optometrists to go to and sort of bringing their level of expertise up is a really important part of that puzzle.
Yeah.
Thank you. Thanks, Dr. Spencer. It's good to see a little bit of an idea of what goes on in the real world. And so as much as we don't like to admit it, we're not in the real world here at the Moran Eye Center. We're our own little world. And so for residents, we're going to go out into
So, we change topics quite a bit. I'm a biochemist, molecular biologist, and I think I was invited to present here because I do something translation. My topic is ciliopathies, and my protein or my gene is called IQCD1 or NPHP5. Sounds very complicated. It stands for IQ domain containing protein P1 or nephrocysteine 5. This protein, when mutated, causes senior-local syndrome in patients, in human patients, and we are producing mouse models to replicate or see differences in mice with mutations in the same gene. So senior-local syndrome is an autosomal recessive disorder characterized by nephrophthisis and progressive retinal degeneration. Worldwide prevalence is estimated to be 1 million, so relatively rare. The disease was discovered more than 50 years ago in papers published in 1961 by Dr. Seymour and Dr. Lopen, who gave them the name of senior-local syndrome. There are only 6 genes involved in senior-local syndrome. They're called NPHP1, 4, 5, 6, and 10. One is still unknown. And I have 2 students working on those genes. One is Christian Hanke, a graduate student from Germany, and Michelle Reed, a graduate student of the neuroscience program at the University of Utah. Nico was an MD PhD student in my lab, starting a project several years ago. So what is senior-local syndrome? In human patients, you see diffuse interstitial cell infiltration, fibrosis, tubular atrophy, cyst formation, and end-stage kidney disease is around 13 years of age. In mice, you see mutant kidneys become smaller, shown here. The mineral is reduced, and cyst formation can also be seen. So it's a mouse nephrophthisis, not generally one of my favorite genes. It's another gene which does not cause retinal degeneration, just nephrophthisis. So the eye disease is retinitis pigmentosa or LCA, Leber congenital amaurosis, and it's pretty well known to most of you. Compromised peripheral vision, tunnel vision, abnormalities in RPE and cones, and eventual leading life blindness. So I made this picture to show you the complexity of the nephrocysteine genes going from 1 to 19, and all those different colors are different domains in there's virtually no relationship among all of those proteins. There's no sequence similarity, and the function of all of those proteins is unknown. The proteins causing serial open syndrome are in yellow, and the other proteins, the other mutations in those genes cause Beckett syndrome, Bardet-Biedl syndrome, and Schubert syndrome, which are synopsis, syndromic synopsis. So I'll just give you a very short introduction to the photoreceptor nomenclature, so you are all on the same page in the rest of my presentation. Photoreceptors are in outer segments and inner segments. They're connected by what was previously called the connecting cilium, and is now named the transition zone. The transition zone between inner and outer segments. And you see there are lots of discs containing the photoreceptor cascade. There's an axoneme, which is basically the backbone of the outer segment, and I made an enlargement of the axoneme to give you all the nomenclature we use in the next few slides. The axoneme is a single microtubule arrangement. The transition zone is a double microtubule. And there's a basal body, which is one of two centrioles in the cell. The basal body, which is important for generating transition zone and axoneme. And then there's a daughter centriole. So, also important is photoreceptor outer segment development after the birth from 2 or 3 years of age. We see that at the neonatal mouse, the basal body belongs to the cortex of the cell, and at P3 it pushes a little bit of a membranous model here, which will be a transition zone shown here, and eventually inform an execution in the view. So this takes about 3 weeks from birth in mouse, and we are mostly interested in mutations that change this arrangement or prevent photoreceptor formation. So the basal body, as I said, is very important. Basal body and axoneme are very important for the photoreceptor discovery. Without them, the photoreceptor would be very unstable. So this shows you, it's taken from an independent paper, shows you that all the resistance are closely connected, either directly or indirectly, forming a lateral network in proximity, specifically the basal body transition zone in the compartment and axoneme. So now we get to my protein, and you see it has several domains. One is called the molecule, which is a primary binding site. The CC is a control region for protein interaction, and the CP is a site for interaction with the nervous system. So molecular malmutations are associated with single syndrome, shown here, throughout the molecule. So since the disease is recessive, we were planning to make a knockout mouse, and for a knockout mouse we would insert a gene track in one of the introns. The gene track basically prevents translation of the molecule, shown here. So it stops right where the gene track is, the functional protein cannot be made, and the evidence that we have knocked out the gene is shown here. In the control, we see the lymphosystem 5 accumulating at the transition zone, and in the knockout mouse, the protein is absent. So to electroretinopathy at P14, the mouse eyes are opening. We see that the mouse is blind, there's no response. Same at P18. This is photopic for rods and photopic for cones. Again, cones are not active, and the mouse basically is blind at birth. OCT can be used to look directly at plasma, and you see that in the knockout mouse at P28, 1 month of age, we see a LCA type or retinized pigmentosa type phenotype as degeneration of rods. Now this gives you an idea of how rhodopsin is and how other segments are developing with rhodopsin as a marker. Rhodopsin is the visual pigment in the photoreceptor outer segments. MP6, MP10, which is before eye opening, you see slowly developing motor segments, and after eye opening of P15, relapsing in motor segments are very strong. In the knockout, in contrast, you see no other segments developing, relapsing, mislocalizing in the inner segments, and eventually a rapid degeneration, and you see essentially one row of nuclei still present at P30, which most likely is Cohen's only. So degeneration can be assessed by looking at the thickness of the outer nuclear layer, which is on the photoreceptors, and you see there is a relatively little degeneration in the first 2 weeks of age, but after eye opening at P14, there's a rapid degeneration in 1 month. The degeneration is mostly complete. So to our surprise, kidneys were completely normal. This is a kidney section at 1 year of age. In the control, in the knockout, you see there is no difference. So the kidneys are completely normal. This was assessed by Dr. Patricia Ritter at the ARUP at the University of Utah. So there's no uniform diseases in our mouse model. So it is not a syndromic celiac, it's just a non-syndromic celiac affecting only eyes. And kidney cilia, as you see here, are very normal in the mouse. So cilia and kidneys are not affected, explaining why we don't have any form of disease. And this is a picture of mouse ganglion fibroblasts, and these are very important for development during embryonic development. When you see you have cilia in the controls and you have cilia in the knockout, basically unchanged, consisting of this body, ball, central, and the cilia. If this cilia would not be formed in the control, the mouse probably would not survive and would be like non-existent. So this is the reason why we have likewise. Now I'm looking at mechanisms. Why do we have degeneration? We decided to do fluorescence sections and assay the retina. And you see a fluorescence section here, over now in the segment, the transition zone, and the outer segment, the base of the proximal part of the outer segment. And you see something green in here. This is a marker EGFP central 2 calcium binding proteins interacting very strongly with the transition zone and centrioles. So the growth is out of enlargement, and we see a transition zone is formed. Here's the basal body and the outer centriole, and these are the cells. In the knockout, we don't see. We see the basal body and the outer centriole, but we don't see a transition zone, explaining why we don't see it in the second. And this is the second experiment with a protein called hormone 1. Hormone 1 is located at the base of the outer segment, and it's responsible for formation of discs. And you see in the knockout that this protein dislocalizes and doesn't form a disc, the proximal disc, and again consisting with lack of receptor formation. On the ultrastructure level, we confirm that the control retina forms, here's a basal body, forms a very nice transition zone and little macromembranes, which eventually develops into a segment. And in the control, in the knockout, we see a basal body and a little bit of an extension which resembles a stunted transition zone, but it's not a normal transition zone. And at a later age, at P10, you see all the segment formation in the control, basal body transition zone, actually all the segment, and there's no other segment in PHP5 knockout mouse. So what we have learned is PHP5 knockout was made. Clinical phenotype is LCA, a non-syndromic cirrhosis. Degeneration of mutant rod photoreceptors is complete at 1 month. Mutant kidneys do not develop nephrophysis. Nodal cilia or ganglion fibers are normal. Photoreceptor transition zones, axons, and outer segments are absent. So we would like to know more details about cones. Cones are important for daylight vision. If we can figure out a way to rescue cones in those mice, maybe vision can be restored. So the way to go for cones is to make another normal mouse with an NRL transcription factor and on the left is the neuroretinal-induced sequence transcription factor. It is required for watch development. If you get rid of this gene by knockout, we would make a mouse that develops only cones. So that's of course a very nice experiment, because in the wild-type mouse we have only 3% cones and 97% rods. So we can now, with this mouse, focus on cones. And you see here a development of cones from 15 to 3 months into the control mouse. And you see again our centrioles and transition zone in the other segment, the corneal segment forming. And in the animal level and the ordinal level, we see a beautiful thick organelle. This is only cones, not rods and eliminated. And in the control, we see our 2 centrioles, no transition zone, and surprisingly, at 3 months, there's essentially no degeneration of the cones. So we have a stable situation of at least 3 months, where the cone degeneration is basically very, very slow, and we have a window of 3 months or longer for gene therapy, for gene replacement therapy, and rescue cones. So this is shown here again, looking at organelle thickness. It doesn't change for a period of over 3 months, not significantly at least. So in this part of the experiments to come up with a virus for gene replacement therapy, on the left is a vector for transcription of tissue culture experiments, and this would be a shuttle vector for producing a virus that can be injected into the subpeptide space, expressing nephrocysteine-5 and hopefully initiating pseudogenesis in the second formation. And we have a window of 6 months to do this. So I mentioned at the beginning we're trying to do a similar set of experiments with NBHP10, and NBHP10 is known to cause hemorrhagic syndrome in human patients, and so far we have produced a knockout, and we see the knockout produces a body bleeding syndrome like phenotype. It has 6 digits, and unfortunately the mouse does not survive. It's a neonatal mouse just born but not alive. So the future of those kind of experiments is to make a vector-specific knockout and maybe design a second set of gene replacement therapies with NBHP10 mice. So this is a summary slide. NBHP5 null-alleles in human forms Seymour-Hogan syndrome, null-alleles in mouse affected with retina, kidneys are normal, no knockout, and written was degenerate within 1 month, and bones are very stable and survive up to 3 months or possibly even 6 months, allowing for gene therapy. This is my thank you slide. Thanks to our thanks from the National Institute, but the research department blindness has another institute and for the development foundation for blindness and the research foundation making small grants to support our blind students. Thank you.
So Wolfgang, obviously fascinating, and indeed, if we could figure out how to decouple rod degeneration from cone, it would make that disease.
I think the chances are very good. The chances are very good in mouse, but I can't guarantee it will work in humans the same way, because for mouse to human is a large step. It would include a large animal model in between, maybe a dog model. It is a dog model for Seymour-Hogan syndrome with NBHP5. So if we can do it in a dog model, we have these modifications of the shuttle vector and the virus, we may be able to get there.
So I don't know if you mentioned, but everyone, Wolfgang's our director of research, as well as all of the other work that he's doing, and we're just very proud of the outstanding work he has. And Nico, who he's talking about, is one of our residents. Where are you, Nico? Raise your hand. Nico here?
I think he's on call.
He's on call. So
He said he's on
it
call.
shows you how there's this interesting combination of the people working together to do interesting things.
I actually wanted Nico to present his, but he said he's on call. So.
Well, we do that too, we get it. Anyway, very exciting, and you know, how you've gone through this and the potential to exchange that coincide with the recognized doesn't use keep growing.
So your mouse model of FPH5 is mostly an LCA type thing. At least in humans, it's not quite that bad. How do you reconcile that? Those patients with severe local need tend to be more simple.
You know, differences from human to mouse are very common. I have many genes which cause LCA in human and then knocked out as in phenotype. So, and there's a dog model, it's the same mutation, it's a frame shift mutation in the PHP5, and this dog has a late onset recognized pigmentosis. So there is an axoneme form as a transmission zone and all this, and another segment by the channels.
So Wolfgang, with the NPHP5 mouse knockout, why do you think that gene is not required for kidney development, or do you think that there's another gene that rescues the phenotype?
The short answer is redundancy of nerve systems. Redundancy, there are so many different systems, and some of them can replace the function or substitute for the function that has been lost. So it's really depending on the tissue and on the cilia in the brain, kidney, and liver. So it's a different situation.
So another possibility in human therapy would be to stimulate another one of those proteins to kind of step in.
That would be a fantastic idea if that can be done.
Well, thank you, Wolfgang, and thank you to all of our morning speakers. We'll break for lunch now. Please try to come back so we can get back on time at 12:50. And then we'll go ahead and we'll get started with our guest speaker this afternoon. Thanks.
You want to do that first? Yeah.
Probably in some underground wall in Alaska. Far away.
Just get it for me. Like doing transcranial orbitopmy.
Well, we did some transcranial work
Dr. Feld is one of those rare individuals who can combine basic and clinical research, clinical care, surgical care, teaching, and administration, and we're really delighted to have him with us. Last night he gave a fantastic talk, kind of bringing together the clinical care and basic science research around thyroid eye disease, and we're so glad he could be with us.
That this is really bringing coals to Newcastle because your neuro-ophthalmology group are much more expert in idiopathic intracranial hypertension than I am. And usually what happens is that, like, the residents beg me to give them lectures on thyroid eye disease, so I never talk to them about thyroid eye disease. So I'm assuming that there's maybe a little room for some getting caught up on idiopathic intracranial hypertension, even though much of the great work has really come out of this institution, and then sort of the mother institution, University of Iowa, that sort of gave rise to the interest in idiopathic intracranial hypertension. So I hope that I'll get corrected for any misstatements I make, and we'll all learn. So it turns out that idiopathic intracranial hypertension has had a few other names in its history. Pseudotumor cerebri, really nobody liked that term because it's had the word tumor in it, and people forgot about pseudotumor. And then the residents would always get confused between orbital pseudotumor and pseudotumor cerebri. They'd use them sort of interchangeably, which would be great, except the diseases are completely different. And then benign intracranial hypertension was actually popular until really the Iowa group said, you know, it's not so benign. Patients are going blind, and we really shouldn't sort of color or bias the outcome of these patients is serious enough by calling it benign. So now we call it IIH, which is a mouthful. And so if someone in the audience can come up with a better name for it, I'm sure there's room to change yet once again. I'm going to start out with a case. This patient is a 27-year-old, 5'3" woman, which in my house is tall, but in most places it's short, and overweight, and she had a history of a renal stone, actually. She was treated with IV antibiotics, including vancomycin, but wasn't really treated with tetracyclines or anything like that. And within 9 days, she developed blurred vision. And her vision, as you can see, was really reduced, 2400 in the right eye, 2070 in the left eye. And this is like, you know, the grand poobah of papilledema. I mean, this is about as bad as papilledema gets. So this was not your usual case. A lot of hemorrhage, a lot of disc swelling in both eyes. The blind spot, as you might expect, was increased, and there were central scotomas in both eyes. And here you can see on Goldmann fields, yes, we still do Goldmann fields, and you can see that there's bilateral centrocecal or central scotomas. A bit about the criteria for making a diagnosis of idiopathic intracranial hypertension. So up until very recently, it's the modified Dandy criteria that we have used, and so you have to have the right symptoms, headache, nausea, vomiting, transient visual obscurations, or papilledema with no localizing signs, but you're allowed to have diplopia from a non-localizing sixth nerve paresis. Patient is otherwise in good shape, awake and alert. There's no evidence of thrombosis on CT MRI, and the LP was supposed to be greater than 250, 25 centimeters of water. I used 250
250 millimeters and 25 centimeters interchangeably. So if I slip, it's not 10 times the amount of hypertension. And there's no other explanation for the raised intracranial pressure. So this is the criteria that we traditionally use. And then it got a little bit more complicated, and I won't bring you through all this, but this is a new classification with Kathleen being involved, and this with Deb Friedman, who was my fellow and was at Mine Institute for a long period of time before moving to Southwestern, and things began to change in terms of what's included. And I'd just like to call attention to the fact that there is such a thing as tumor cerebri syndrome without papilledema. And this is kind of a new concept. People had intermittently reported, well, you can have high pressure and no papilledema. I always had a little saying, I have a number of sort of maxims that I use for optic nerve disease, and the maxim that corresponds to this is that the optic discs are not the manometer of the central nervous system. And so you don't have like a gauge sitting there at 260, it turns into papilledema, and at 240 it goes, you have no papilledema. So different people have different tolerances for different pressures in terms of developing papilledema. But there are other things that have to be present to make sure this isn't a different kind of headache. For instance, emptycella, that you can have flattening of the posterior globe, and that you can have transverse sinus stenosis. So these are things just to be aware of that still in evolution, exactly what we mean by elevated intracranial pressure. So what are the hypotheses? Well, because we don't know, everything you say is plausible. Dr. Sugarman did a bunch of studies where he said, you know, these patients are heavy and they have weight on their inferior vena cava and their superior vena cava, and so they just can't circulate their blood, and you get high venous pressure, and this is what the underlying problem is. But really, it doesn't really fit for most people that this is a logical extension. Sleep apnea is regularly associated with patients who have IIH, but it's not the other way around. If you go to sleep clinic, you can examine thousands of patients and they don't have IIH, nor do they have AION or all the other things. I think that having sleep apnea just means you're more susceptible to just about everything, including IIH. Hormonal influences, again, you know, the vast majority of patients are women. Why should that be so? Well, maybe there's some hormonal influences, but no one's really identified what those hormonal influences might be. Of course, you can increase CSF production. And in certain papillomas that involve the choroid plexus, you can actually get increased CSF production and overcome the absorption system. You've heard that term before. Decreased CSF absorption is probably what's going on most of the time, but we don't know exactly why. I did see one interesting article just recently, which I haven't had time to read in detail yet, talking about aquaporin 4 defects as being associated with IIH. So that'll be interesting to follow up to see whether that has any validity. And then there's a lot been said about functional or mechanical obstruction of the venous sinuses. So if you raise somebody's intracranial pressure, the tissue pressure collapses or can collapse segments of the venous system. On the other hand, if you collapse a segment of the venous system, then you get higher venous pressure, which automatically gives you higher intracranial pressure. So these are some of the ideas, but the fact of the matter is that we just don't know. And we were hoping that the study I'm going to talk to you about today was going to give us some more clues, and it has not been as satisfying as one would have hoped. So the clinical presentation, as I've already alluded to, is obese young women, usually with recent weight gain and headaches that are often constant, horizontal binocular diplopia at distance because they have abducting paresis, transient obscurations of vision, which are usually postural induced. They last seconds at a time. They can be in one eye or both. Some patients do get nausea and vomiting in association with it, which really makes it confusing for patients who may be treated for migraine for a period of time because they have nausea, vomiting, and headache. And here's another syndrome with nausea, vomiting, and headache. Pulsatile tinnitus is a noise in the ear. This is not the high-pitched sort of whine that is common, but rather this is this whooshing sound that is sometimes pulsing. Mild stiff neck because of the increased intracranial pressure, but there are no localizing symptoms. So of course we always want to see if we can find a cause. So if you eat polar bear liver, then you are in fact at some risk of developing hypervitaminosis A, which can give you papilledema. I think at least all the third-year residents know all about nalidixic acid, and I've never seen nalidixic acid used as an antibiotic since in my entire career, but Cipro is an analog of nalidixic acid and can cause the syndrome, so that's a little pearly. Corticosteroids are coming on or coming off, so it's really complicated. It's also used by some people in the treatment of IH, so it really becomes complicated, and we try not to use corticosteroids. Closed head trauma, probably from venous stenosis or temporary venous stenosis, and then history of coagulopathies. Again, we think about venous occlusive disease as being perhaps associated with increased intracranial pressure. The signs, so the vision can be fine, and often is fine. As a matter of fact, the IH treatment trial had patients who didn't have much vision loss, and that's one of the strengths and one of the weaknesses of that study, and we'll get to it in a little bit. They can have ciliary defect, visual field defects of any type, and as I said, they can have abducens paresis. The papilledema is usually bilateral and symmetric, and I'll show you some evidence for that later. The neurologic exam, there has been some thought about, with all that elevated venous pressure, the arterial circulation must be affected in some way, and perhaps cortical perfusion is compromised. But very few patients we see are confused or somnolent or anything like that. So we want to do some tests. So the first thing we do is to get an imaging test. So I would say, imaging first, then LP. You wouldn't want to image something and find that the pseudo tumor was really not pseudo, and that you end up causing complications by doing an LP when maybe you shouldn't. So we get MRIs and MRVs. In our institution, if the patient is the typical onset, we usually don't get MRVs, we just get MRIs. Some places do both all the time. Anybody who's atypical should have an MRV, or now I guess they're getting CTVs as well. Lumbar puncture, so I used to do them all myself. And the problem was that, about 4 hours a week I was doing LPs, and then they found out I didn't have hospital privileges to do LPs because I'm an ophthalmologist, and so I had to go back and get privileges and prove that I actually didn't paralyze anybody or anything in doing the LPs. But now we have a PA who does them under fluoroscopy, and I can tell you that, it's just a wonderful thing to have when you know that person's doing them right, because doing them wrong is a real problem. You can't say anything about how that patient is, what that patient's opening pressure is. If they're sitting up, squeezing, there's 100 ways to do it wrong. They're all equally easy as doing it right, but if you do it right, you'll get a pressure you can rely on. And blood tests in those cases that have venous thrombosis, we like to make sure that there's no underlying cause for venous thrombosis. So Lars Friesian, who happened to be a fellow with Bill Hoyt when I was a medical student and got to know him extremely well, very, very detailed and individual who is truly brilliant and has done a lot to help us with our understanding of optic nerve. He was sort of the premier disc gazer for decades. And he came up with a system of papilledema that allowed us all to talk about the same things. And so this was what was used in the IHTT study. And so just to review briefly, basically stage 0 is a normal disc or a not normal disc, but with no C-shaped halo. That's very confusing, and it causes a lot of consternation amongst all of us, and I'll show you why when we get to the results of the trial. Stage 1 is this C-shaped halo, and it doesn't always project well, but basically what it is, you see white, a white fuzzy area that doesn't include the maculopapular bundle. So if you see white around the disc, then but it doesn't include the maculopapular bundle, then that is stage 1. Stage 2 is that the halo goes all the way around, there's elevation of the nasal border, and there's no major vessel obscuration. So 0, 1, 2 all depend upon what the nerve fiber layer around the disc looks like. 3, 4, and 5 talk about vessels. And so in 3, there has to be at least partial obscuration of one vessel. In 4, you have to have some obscuration of all vessels. And in 5, you have to have complete obscuration of at least one vessel on the disc. And again, you can say this, there's room for interpretation with all these things. But in general, it turned out to be fairly reliable. And they were both, in the study, they were both judged by the principal investigator at the site, as well as by photography, which is where my group came in. And so this is what we did. In addition to looking at the qualitative classification, we actually we can stereo the disc, we can blow them up. So the size of beach balls, so every disc is sort of beach ball size, which allows you to see a lot of detail. And we stereo it, we can do a lot of things that help us to actually calculate the area that is involved. And when we do that, we came up with 2 different areas. And so we came up with what we call the area of white, which is the halo. So if the halo goes all the way around, and we looked at the vertical and the horizontal, and we would calculate the area of the halo, and then we calculate the area which we call the dark zone. And you can see that on the hill of the papilledema, outside the white zone, it's still elevated off the surface of the retina. And so it comes out as a dark shadow, and it also is the inflection point of the vessels. And so you can then get an area of dark. And we looked at both of these separately as well as together. And so what happens when you try to do a treatment trial? Well, here here's an example from a patient in the IHTT, and here's what they look like at baseline. So this is, pretty much all the way around, and I think there's a vessel obscured. There are several vessels obscured. This was called a level 4. Okay, so this is a Frisian 4. And then 1 month into the study, you can see that it's still got a halo all the way around, but now you can see the vessels that you couldn't see well before, and now it's a 2. And then it's, you look back at month 8, and it was still a 2, and then went to a 1, and then it went to 0 at 9 months. So this is a really nice case study of how you can follow papilledema, look at response to treatment, and if you now look at it from the standpoint of the area of white, you can see the area of white goes down mostly at the beginning, and then it slows down, and similarly the total area also continues to go down and then flatten. And so, in other words, this disc size is not very much different than this or this disc size, but it is different from this one and from the first one. So we have a nice correlation between the qualitative and the quantitative.
Then we took this quantitative assessment and we started looking at it against other parameters. And the reason I show you this is that, first of all, it's published. If you're really interested in the data, it's all there. But there are a lot of things that really didn't help us very much. And so you can see that the curves really are not too exciting. There's a lot of scatter. When you're trying to correlate it with visual fields, visual acuity, color vision, all those things, it doesn't always correlate as well as you might want it to. So what are the management principles of IH? So traditionally, we have a few things available to us. We have medical therapy, of which weight loss is the mainstay, and we all recommend that patients lose weight. Of course, it's easier said than done, and in the IHTT, we actually had an obesity specialist group work with each individual enrolled to lose weight, and you'll see they actually lost a lot of weight, which was helpful. And then Diamox or cezolamide has always been the mainstay of treatment for 40, 50 years, but never shown in a class 1 level study, no prospective study, that demonstrated it was useful, but everybody tended to use it. A lesser known drug, but one I find very useful for patients who are not tolerant to Diamox, is Neptazane. Neptazane, so if you're doing 250 milligrams of Diamox twice a day, which is a really low dose, you'd be doing 25 milligrams of Neptazane twice a day. So it has 10 times the potency, but it seems to have less side effects. And so I use it in patients who seem to be sensitive. Topiramate, there are no clinical studies, but it is a mild carbonic anhydrase inhibitor. It's really good because it gets rid of their headache, it helps their headache, and it's also a hunger suppressant. So it really decreases people's appetite, and so they lose weight. So a lot of people, if they don't tolerate Diamox, they'll go to topiramate. Remember, there is topiramate that can cause swelling and closure of the angle, so every once in a while you can compound your difficulties with topiramate. Lasix is interesting. Lasix is sort of the fallback drug. Oh, they can't tolerate Diamox, oh, they're pregnant, oh, they're this, and so we put them on Lasix. There's really no good studies that demonstrate that LASIK is really effective. Patients really don't like it. It makes them pee all the time, and you have to watch their potassium, and it's more complicated than, in general than using acetazolamide. So as I mentioned before, we want to avoid steroids if at all possible because of rebound on tapering and because the side effects include weight gain, and we know that steroids can either start with the onset of using corticosteroids, or IH can start as you discontinue it. So it's really hard to manage. Sometimes it's unavoidable. Patients who have severe vision loss, you can sometimes rescue their vision for a period of time with a short course of steroids. So surgery is generally used when medical therapy fails. And the surgical therapies that have come about have been usually optic nerve sheath fenestration, and there's one eye or both eyes, and the indications tend to be primarily for vision loss, not for the headache. LP shunts, which we try not to use anymore because even though they work, about 50 to 60% will have some complication soon after they have the LP shunt put in. They get infected, they get disconnected. Your lower back was just never made to hold the shunt. So ventricular peritoneal shunting, it takes a little bit more skill. You have to stereotactically place the catheter. You can get intracranial hemorrhages, you can get swelling, so it's not completely without problems. It has the same effectiveness in LP shunt, and even though the initial success rate is high, they also have a substantial failure rate. So it's certainly not a panacea, and the neurosurgeons hate doing them. So it's not like you have to convince them that you want to do an optic nerve sheath fenestration. They're sending them to us to say, won't you please do an optic nerve sheath fenestration? We have to tell them, no, it's not indicated. You really need to do the shunt.
So optic nerve sheath fenestration, there are really two ways to approach it. I still use the medial approach that was first standardized in the ischemic optic neuropathy decompression trial. I think you're looking at it under as much power as you want under the microscope, and this is very early on. I think John Keltner in the 70s published the shunt that occurs between the subarachnoid space and the interorbital space, demonstrating fluid. But there's also been some demonstrations the scarring takes place, and some people feel that the scarring that takes place may protect the nerve from swelling, but also cause further vision loss down the line because the pressure on the nerve back of the disc is still there, and you haven't really done anything for the pressure. So I don't know if this is going to work or not. I don't think it'll work, but it was just a 10 seconds showing a gush of CSF from a super sharp blade. So a long time ago now, I guess almost 10 years ago, I wanted to look at what the effectiveness of surgery for IH was, because nobody had actually done any systematic research in the literature. There's much more data on looking at optic nerve sheath fenestration because ophthalmologists were seeing those patients and got visual fields. But if you're being referred from a neurologist to a neurosurgeon or to a neuroradiologist, they somehow never stopped in the ophthalmologist's office. And so most of them just had subjective, my vision's better, my vision's not better, or at best they had a visual acuity on them, which isn't a very good measure. But basically what it demonstrated is that we really don't have too much data on many of the surgical procedures except optic nerve sheath fenestration, which has like an 80% effectiveness. So and this is in terms of vision improvement, 80%. So it's a pretty good thing to do if the patient's complaining of vision loss. There's not that much to say about it relative to headache because, of course, ophthalmologists never send their patients to a neurologist so they can ask about whether their headache is better. And so we don't really know much about the effect of optic nerve sheath fenestration on headache. So let me go through, these are Mike Wall's slides. These are the part of the official slide set, or the IHTT, and this has all been published now, and I'm going to show you a few things that haven't been published, but or have been published in subsequent to the initial data. So here's the steering committee, and you can see that we had really good representation from Jim Corbett, Deb Friedman, and Mark Cooper-Smith, Mike Wall, all people who have really a vested interest in IIH over their entire careers. And here was the study. Basically, it was diet plus placebo, or diet plus acetazolamide. And the acetazolamide could go up to 4 grams. So the deal was, if they could drag themselves in the office and they weren't complaining too much, you increase the dose. You kept increasing the dose. And normally, I would say the clinical idea was you got to 2 grams and you pretty much stopped. But now we feel much more comfortable about going actually to 4 grams in order to get effectiveness. And and then you monitored them, and perimetry was the outcome measure. Optic disc photos were taken at regular intervals, and at 6 months there was statistical comparison of these 2 groups. Here are the centers, and you can see that here you guys are. I don't think you're that far north. I think you're kind of more like there, right? But
we're north. We're right there. Second view of you.
That's it. You're there. Okay. All right. Well, you can see that it's heavily East Coast based. I guess we have more patients that have the disease or something, but Rochester was one of the centers. SUNY was another center. So we have a lot of there was involvement across the country and actually in Canada. What was the BMI in this cohort? And it was hefty, you know. So I think the definition of obesity is a little greater than 25, is that correct? And so these people were obese, obeser, and obesest. The initial symptoms of IH, headache and vision loss were the first two, headache plus vision loss, pulsatile tinnitus, and then there were a few that were asymptomatic. Look how, what a small percentage actually had diplopia. So I think it's overemphasized that you should have diplopia. We just don't see that many patients with diplopia. And the frequency of symptoms, again, headache and TBOs were the most frequent. Interestingly, back pain turned up. We don't know if this is back pain before or after the LP, but it's certainly one of the complaints. Pulsatile tinnitus, dizziness, which is interesting because one wouldn't expect necessarily them to be busy. Photophobia, perhaps related to headache, and again, neck pain, vision loss. So you can see the relative frequency of many symptoms that occur, some expected and some unexpected in IH. So John Keltner tells us that this is the most common field defect that's experienced, which looks kind of like an arcuate. Interestingly, the lower field seems to be more susceptible than the upper field in many of these patients. How about the severity of papilledema? Well, you know, this is a nice bell-shaped curve. Remember that these patients really didn't have more than a couple of dBs of depression on their visual field. And so we are seeing only the mild IIH cases. And it's interesting that it's sort of a bell-shaped curve around grade 2 to grade 3, and almost no grade 5. And of course, there are virtually no grade 0s. And in the study eye, there were some in the non-study eye. One of the things that wasn't published is what was the symmetry between the eyes. And so this is a calculation that I performed in my lab, looking at symmetry. And because unilateral papilledema is always a differential diagnosis, so could, you know, is this ischemic optic neuropathy or papillopathy of some sort, or is it optic neuritis, or is this IIH? And so it turns out that virtually almost all but 5% had within 1 grade to either direction of the study eye. And that's really helpful to us, I think, because you know, the more advanced IIH patients, they almost always have bilateral disease, but even in the milder disease, bilaterality is certainly the rule. And again, you know, we looked at the relationship of papilledema to visual loss. We'd really like to say, well, the less edema you have, the better your pressure and the better your vision. Didn't work out that way at all. It seems to be completely random. And similarly, we said, well, you know, if the manometer of the central nervous system really is the optic disc, then there should be a really good relationship with the CSF pressure and with mean deviation, and that didn't work out either. However, what did work out is that we found to the 0.05 level exactly that there was a benefit to using acetazolamide, and in doing it by increasing the doses in the way that I just described. And most of the effect took place in the first 3 months. And so after that, you can see that these lines are almost parallel between the placebo group and the acetazolamide group. But what you see is that as soon as you got an improvement immediately in the acetazolamide group within a month, and then but not in the placebo group, and that accounts for most of the difference. What about symptoms? Well, you can see here that acetazolamide plus diet seemed to improve TBOs, pulsatile tinnitus, dizziness, photophobia, neck pain, and visual loss very, very nicely. The diet seemed to improve some cognitive, the diet alone with placebo seemed to improve some more vague symptoms like cognitive dysfunction, diplopia, and radicular pain. So that's not too unexpected. Percent improvement, difference over 6 months. You can see that with the acetazolamide that you got tremendous improvement in the transient visual obscuration, some improvement in headache severity, and some improvement in the frequency of headaches. So what was the average dose of medication? Well, it turns out that that if you needed a lot more placebo to get an effect, if there was one. But so that's not too surprising. What was surprising, I think, to most of us is that people tolerated 2.5 on average, and many people were actually on 4 grams a day. And the effect of acetazolamide on Frisian grade was fairly significant. The effect of placebo, of course, in the other direction. So how many treatment failures were there? There were 7 treatment failures in this whole study, which basically says you can leave most of these patients alone, they'll do fine. On the other hand, since we wanted to find out if acetazolamide would actually help, it turns out that there is a significant difference between the treatment and the placebo group. Oh, by the way, I guess I should point out that all the patients who failed had high degrees of on Frisian scale when they presented. This just shows you the change in papilledema grade in the worst eye over time, and you can see that even the placebos did pretty well. They gradually got better, but they never got down to where the acetazolamide group is. And this is just to remind you again the progression from grade 0 to grade 5. What is interesting is to look at baseline in 6 months. So here's the baseline up here, and you can see this sort of, as I've already showed you, kind of a distribution, normal distribution in both the baseline of both the study group and the acetazolamide group. But then when you look at 6 months, you can see that the lower numbers, 0 and 1, are predominant in the acetazolamide group, but you're still somewhat normally distributed in the placebo group. This is, again, something that isn't in the study. It's just a little study I did, which says, well, what do all those disc hemorrhages mean? And what you find out is that the patients who failed had a lot more disc hemorrhages. But on the other hand, they were also higher grades of papilledema. And so when you have higher grades of papilledema, you're probably more likely to have disc hemorrhages. I'm not quite sure what it means, but I now know that disc hemorrhage is not a good thing to see in a patient with IH. One of the sub-studies was to look at OCT and to look at OCT volumes of the nerve. Very interesting study. So here you see papilledema grades from 0 to grade 4. They didn't have any grade 5s in the subgroup, or they couldn't measure them. And here you see the OCT, and you can see that it's a pretty good correlation that as you go up in papilledema grade, you get more and more volume. And this is the 3-dimensional reconstruction of those curves. So it's very pretty, and it may allow us to be more quantitative moving forward. And here you can see over time, this is volume over time in the placebo and the acetazolamide groups, and you can again see that you can use disc volume as a measurement to demonstrate the differences between the acetazolamide and the placebo group. There's also a very interesting phenomena where, so this is getting back to umbilical science. So we have the RPE that comes in papilledema, the innies, and then as it gets better and you treat them, then it deflects posteriorly and they become outies. And so this may be a sign to tell you whether papilledema is progressing or regressing. We did look at disc area versus disc volume, and it is an amazingly good correlation, which I guess one would expect. But what it really means is the z-axis doesn't add much in terms of understanding. If you can quantitate the differences, OCT is much easier to quantitate than taking measurements using big screens, but the correlation is just amazing between total area and OCT volume and baseline study eye, baseline non-study eye, and in 6 months study eye, non-study eye. So very tight correlations, and that's, I guess, reassuring. But stay tuned, because we didn't address a whole bunch of problems. Especially, we didn't address patients that really worry us with more severe symptoms and signs of IIH, and we didn't look at any of the surgical arms. So we started 2 other studies, the LIGHT study, which I think has come to a conclusion now, and the LIGHT study was just to continue those same patients in group 1 to see what happened to them long term. Basically, what happened to them is they got bored and didn't show up for their follow-up appointments. And in the surgical side, we now have the site, and the site is, we'll find out probably within a few weeks. Whenever council meets in October, we'll find out whether they're going to fund this project, which is the natural extension. And the site study is looking again at parametric mean deviation, but these are patients who have from -8 to -30 dB loss on the visual field instead of like 0 to 6. And they're going to be randomized into an acetazolamide medical treatment, optic nerve sheath fenestration, or CSF shunting technique. And so we're going to try to figure out by what maximum medical therapy does versus, and this is the same thing that we just talked about, versus doing surgery. They're going to be monitored with visual fields, and now OCT is the other outcome measure. And then we're going to look at the results and see how they fare. So we really need to get back to that patient I showed you. So what did we do with this patient? I've given you all this data and talked all about this disease, but here you have this patient in front of you, has 20 terrible vision in both eyes, and is really, probably the clock is really ticking. So what did we do? The patient had already been taking 1.5 grams per day of Diamox at the time she was referred. So I really didn't think we had a whole lot of time to figure out whether or not maybe going to 2 grams or 2.5 grams is going to be effective. So she went and had a right optic nerve sheath fenestration, and I mean, this is great. 20/40 vision, remember that was just really bad, 2400 vision preoperatively. She comes back for first post-operative visit, 20/40. And the left eye, which we didn't touch, hand motion. So does anybody have an idea what happened? Operated on the wrong eye. So what happened to this patient? Here's the visual field. So in the right eye, there's just this big blind spot, but overall pretty good. And this is the left eye. I mean, just disastrous.
Probably an ischemic, right?
Well,
does she have an APD now?
So that was one of my thoughts. My other thought was it was the resident's fault.
Well, that, obviously.
The resident said it was the medical student's fault.
Is there an APD?
Yeah, there is an APD.
Okay, great.
But it's sort of, but not the one you think about. So here's what happened. This patient had a vitreous hemorrhage, probably because of hyperventilation during the time of surgery. And it's one of the very few patients I've seen with IIH develop a breakthrough hemorrhage into the vitreous. And when I last saw the patient, after one of my retina colleagues cleaned all this up, visual acuity is 20/30 in the right eye and 20/100 in the left eye. It wasn't completely resolved. There was no APD at that time, and the color plates were back to normal. So just to show you, when you think you've seen everything, then you get to see one more. So thank you very much for the opportunity. And I'm happy to answer any questions you may have.
Actually, I may have missed this when you were going through there. Did they follow weight loss compared to the placebo compared to the Diamox group, or was there a difference?
Yeah, interestingly, there was a difference, but it wasn't due to the use of the Diamox. It was a very sophisticated system, because the patients on Diamox lost more weight because it takes away your appetite. Because makes Coca-Cola taste bad, and you know your tongue is vibrating all the time. It really doesn't. You don't want to eat it when you have this on. So when you took away the dependent variables and looked at them as independent variables, there was no difference due to the weight. They both lost weight, about the same. Yes.
Thank you, Dr. Felden, for a great presentation. I actually have two questions for you. So question number one, you mentioned acetazolamide, 250 milligrams. So do you prefer to use 250 milligrams tablet or 500 milligrams capsule? And the second question, so what do you usually do when you have a patient with kidney stones, medications-wise?
So the first question, if I heard it correctly, was just about how do I prescribe the pills? Is that correct?
250 milligrams.
250 versus 500.
Yeah, the tablets versus the capsules.
Yeah. Yeah. So of course they went in 250 milligram increments for the purposes of the study, but I used the long release 500 milligram capsules, and as I increase it, what I do is I ask the patient, are they more symptomatic from the Diamox in the morning or the evening? And as I build up, I'll give them more when they're less symptomatic from their Diamox related effects. But I don't know that anybody, again, there's no study that shows that one's better than the other, but you can almost depend upon patients trying to take medication 4 times a day aren't going to take it 4 times a day. So you're very fortunate if you can take it twice a day. And the other question in terms of, you're asking about failure?
Kidney stones. If you have somebody with a history of
kidney stones. So we had one patient who had kidney stones. The patient here who had the history of kidney stones, it turns out that you can, even if they've had a kidney stone, that you can put them back on and they probably do fine. That, you know, you have to make sure that look at their urine from time to time, make sure there aren't a bunch of oxalate crystals that are forming, but in general, you can put them back on. This patient tolerated the Diamox fine without any recurrence of stone.
So I noticed in your review from 2007, you had the stent placements as a treatment, but you didn't mention that and it's been kind of hot in the press in the last 5 years.
Yes.
Are you guys doing stenting a lot?
So we are not doing stenting, not because they don't want to do stenting, but I have serious concerns about stenting. And you know, the stents at the time that I published this back in 2007, there were only about 30 published cases of stents. Now, of course, there are probably hundreds. And the stenting.
These are venous stents.
Yeah, venous stents. So they go right into the transverse sinus. I mean, you know, so it's like taking a nail and sticking it in somebody's transverse sinus. And a hollow nail. There were initially a lot of complications, and there were serious complications, hemorrhages, all sorts of things. I think the procedures got safer over the years, and people are more skilled at putting them in, and the shunts are better. But you know, the problem is that most centers are not making a really good differentiation between stenosis, true stenosis, and secondary narrowing. And so, because you know, they're all going to get better if you take care of the narrowing, then you've taken care of part of the circle, the vicious cycle, so it's going to help it get better. But if they truly have stenosis, it's not going to get better really until you do that, or until you have a permanent shunt solution. So, I didn't emphasize it in this talk, and it's not part of the site. So there was not a lot of enthusiasm putting this into the other study. What's your experience here?
We don't do it very often, rarely.
Yeah. There are certain centers, Australia likes to do them. I guess, you know, if you're south of the equator, there's a different fluid dynamic that works better. Any other questions? Thanks again.
So, co-chair that has been AWOL most of the time, so sorry about that. Yeah. Okay, so I made this slide a couple of hours ago, literally after I saw the title of the preceding talk. And the question is, what do these conditions have in common? They look pretty different in a way, but basically if we look at this, what they do have in common is some kind of a pathological stretching or swelling or pushing. So there is some kind of a mechanical thing that is going on. So what I would like to sort of address in this talk is, can we find maybe unifying principles in all kinds of diseases that are afflicting the human bodies? And can we find this through understanding a process that is called mechanical translation? Taking account that pretty much every cell in our body really cares about mechanical forces. If we look at the eye, for example, it is a highly mechanically active environment. So I went to Arvo this year, and there was a poster showing that just rubbing our eye or blinking or getting up from the bed increases our intraocular pressure to hundreds of millimeters of mercury. So there is swelling going on, activity-dependent swelling. There is pushing, there is stretching, there is respect with hydrostatic pressure. So what I would like to leave you with is this idea of this being a highly mechanically active environment. Pushing can cause corneal opacification and so on. So there are all kinds of pathological phenomena that have a very, very strong mechanical component. And what we are interested in, many of them, perhaps most, but what I'll focus on is glaucoma. Basically, when we think about glaucoma, we think about two things. First is, how is IOP regulated in the front of the eye? And the second thing is, what is actually going on in the back of the eye? How do these cells sense pressure? Do they sense pressure, or do they sense stretch, or what is actually going on? This has been a $1 million question. Thousands of papers have been published, and really, we have gotten no closer to the answer. And this answer is what we are looking for here. So how we do, this connects the front and the back of the eye. The likelihood of developing glaucoma is exponentially related to the pressure that patients have in the eye. So there is something going on with the pressure, and indeed we can increase pressure artificially in the monkey and look at the retinas, and you see that the retinas look pretty good, except here. There is this huge loss of retinal ganglion cells. So these guys looked at the sensitivity of the monkey for light, and they found that the sensitivity loss was actually pretty minimal until the monkeys lost about 50% of ganglion cells, which is what we see in humans. In other words, by the time we realize we are getting blind, it's already too late. So we really need a mechanism. We need to understand how this loss caused by IOP occurs. What is the molecular mechanism? Because that is really the only way for us to diagnose early, and that allows us to treat those patients before this fulcrum focal. So the question here is, what is actually going on in the ganglions? And the hypothesis in the field are actually all over the place. Some people believe that retinal ganglion cells are intrinsically sensitive to pressure. Other people say, no, it's actually the glia, and it's the inflammation that kills the ganglion cell. There is a strong strain of thought suggesting there is an excitotoxic stress. Too much glutamate is being released for some reason in the retina. And some people say, no, it's actually endothelial cells and some kind of metabolic thing that is going on. And And this is definitely the case for higher IOPs, which cause ischemia. Another really acrimonious debate that has been going on is whether the first effect of increased pressure is at the optic nerve head or is it at the dendrites? And this is a very important question that still needs to be resolved. So how do we put all of this together? The hypothesis that I'll be talking about today is that all of these things are happening because these cells express ion channels that are sensitive to pressure or to all kinds of mechanical stimuli. We can mimic the glaucoma phenotype simply by activating these channels, and we can protect the retina from hypertension by blocking these channels or by genetically eliminating them from mice. So this is what we'll be looking for. And we are looking at several types of these channels. What I'll be focusing on today is a channel called transient receptor potential amyloid isoform form 4, which is a member of a large superfamily of so-called TRP channels. It's a non-selective cation channel, and what is interesting about it is it's activated by all kinds of mechanical stimuli, from swelling, from stretch, but it's also sensitive to temperature and lipids, such as arachidonic acid. It's expressed all over the body, especially in tissues that are still load-bearing, stretch sensitive, such as the bladder. It regulates uterine, vascular bladder contractions, and it's been associated with mechanical hyperalgesia during neuropathic pain. So something is going on with this channel and mechanical stress. And the novice mice were shown to be less sensitive to painful stimuli and to show less inflammatory responses during mechanical injury. So it's a very interesting candidate to evaluate in a mechanical force-related disease such as glaucoma. So when we started, nothing was known about it in the retina whatsoever. So we looked at it, we find mRNA, we find protein, and when we immunostain, we find that it's very strong expressed in retinal ganglion cells. So the red here is a transgenic marker in retinal ganglion cells, SI1, and you see it very strongly colocalizes with TRPV4 antibody. And the red here is another ganglion cell marker, and you see it's a transcription factor. It's so you see the only neuron in dissociated preparations that express TRPV4 are retinal ganglion cells. You also see this green fuzz here. These are the entity of retinal Miller glia. So we confirm this by immunolabeling with Miller glial marker. So why is this interesting? Because Miller cells and retinal ganglion cells are in fact the cells that are the most susceptible to sort of glaucomatous remodeling within the retina. So we can take a chemical that selectively activates TRPV4 channels, and we can look at we can load these cells with calcium dye, and then we look what is going on with calcium signals. And what we see is huge calcium increases in response to this channel. And what is amazing to us and really interesting is that the pattern of the calcium response in the neuron, the ganglion cell, and the Miller cell is extremely different. So here it desensitizes very quickly, and in the glial cell, the signal is huge and stays on for as long as the stimulus is running. Now, what happens to the light response of these cells when we stimulate with this putative channel agonist? So this we are recording an intact retina home mount. This is a cell that responds to light with spiking and turns off during light off, and you see in the presence of the agonist the cell goes crazy. Excitability goes on like it's turbocharged. We also see increasing spiking in a cell type that goes on with the light and then goes off with the light as well. So there are also more spikes, and when we actually look at the excitability, which we test by injecting tiny amounts of current in the cell, getting spikes, we see that we need much less current to induce spikes in the presence of the agonist than in the absence. In other words, what this agonist is doing it is increasing the excitability, making them much more susceptible to any kind of glutamate or any kind of light stimuli that these cells are going to experience. So producing an excitotoxic stress, basically. Now, this is the case for all ganglion cells, because when we take the retina, we plop them to a microelectrode array, and we stimulate with the agonist, we see a huge increase over 100-fold in spiking that shows kind of a similar time course that we see with calcium imaging. So we are pretty sure that this channel activates excitability, stimulates excitability. What about swelling, which is another mechanical stimulus? Well, when we induce swelling, there is a huge increase in calcium as well. And we don't see it, so this is increasing calcium when we swell, and we don't see it in the non-eyes. Now, are retinal ganglion cells intrinsically sensitive to pressure? Here we record single channels in so-called patches, and we can stimulate with very, very defined, calibrated pulses of pressure, and we can induce spikes. And this is very reliable. When we do longer pulse stimuli, we see, again, inward currents, which are much smaller in knockout animals or knockout retinal ganglion cells, or much smaller when in the presence of highly selective TRPV4 antagonists. In other words, TRPV4 is a pressure sensor in retinal ganglion cells, and when we take it out, they are less sensitive to pressure. Now, can we mimic glaucoma, or can we mimic sort of pressure-induced retinal cell death simply by activating a mechanosensitive channel? The answer is yes. So when we inject the agonist, this is the control eye, this is the eye injected with the agonist, there is a huge loss of retinal ganglion cells. So we can actually reproduce the mechanical phenotype simply by stimulating, chemically stimulating mechanosensitive channel. So what about this question about dendrites versus the optic nerve head? I would like to say that this is something that we are still investigating right now. We don't have an answer to this, but when we culture cells and we can see the dendrites, and we can get localized increase in the dendritic calcium level. So we are pretty sure that this is a way to regulate the synapse formation in the inner plexiform layer. And the newest studies published in Journal of Neuroscience are showing that indeed the first changes in response to elevated IOP may in fact be synaptic. However, when we look at the optic nerve head, the immunostaining is also extremely strong. So it's very likely that by stretching the lamina cribrosa in primates or the glial lamina in mice, one would activate this channel. So we stretched the substrate. We have a machine that allows us to do that very specifically. We can see huge calcium increases in retinal ganglion cells that are missing in about 70% of cells. In 30, we still see some calcium responses. Now, so the knockouts show less calcium increases. TRPC1 knockouts, this is another type of mechanosensitive channels, are not susceptible in TRPC1 knockouts, but all of them are susceptible to the selective antagonists of TRPV4 channels. So in other words, we hypothesize, we propose that TRPV4 is actually a mechanosensitive channel that is sensitive to pressure and that is sensitive to stretch, and that might ostensibly mediate the effect of hydrostatic pressure both at the dendritic and optic nerve head levels. So this is kind of a very simplistic model of what we're thinking. Overactivation by of the channel leads to overload with calcium, and this activates calcium-dependent proteases, caspases, and so on. And we have proved that as well, and leading to some. So what about the second part? What about the glia? So the Müller cells in particular envelop every single retinal neuron. They are absolutely essential for every aspect of retinal physiology. And what is interesting is that they become activated. The first thing that one sees following IOP increase is glial activation together with dendritic and synaptic remodeling. So what goes on with Müller cells? I will skip over a long period of time of work, a lot of work. I will just show that how incredibly strongly expressed, present are Miller cells in the retina, enveloping every single retinal neuron. And if you look from the top, you see these little holes. This is where the cell processes are, the dendrites or the cell bodies and so on. So they strongly express TRPV4, and to just summarize our findings, we nailed down the signaling cascade that is associated with TRPV4 activation. Basically, we think that aquaporin 4 channels, which are the water channels, serve as detonators for activating TRPV4 channels by increasing the rate of swelling during kind of osmotic shocks, but the TRPV4 channels are intrinsically sensitive to stretch and mechanical stress as well. So we are 100% certain that TRPV4 channels are important stress sensors for retinal healing. Now, what about glaucoma? When we induce chronic glaucoma in certain genetic mouse models, or acutely elevate IOP by injecting microbeads in front of the eye, we can get reactive gliosis of these Miller cells. So the question is, can we reproduce this by activating this putative mechanosensitive channel? And the answer is yes. Injecting this agonist induces huge reactive gliosis. So basically, in other words, we can reproduce the key retinal elements of glaucoma simply by stimulating a mechanosensitive ion channel. Now, what about treatment? Can we protect by systemically treating mice with antagonists, or by eliminating the gene? And the answer is yes. So this is a normal eye treated with PPS. This is eye that has experienced elevated IOP. You see there was a very significant degeneration, about 20% loss of RGCs, which you see here. In mice that were systemically treated twice a day with high dose of TRPV4 antagonists, there was no degeneration. We did this many, many times in dozens of mice, and we think this is a fairly solid result. So somehow blocking the mechanosensitive channel blocks that degeneration that we see. Now, when we got this result, we were very thrilled, but we started to worry that maybe the effect is actually not at the ganglion cell. What if we are regulating pressure itself as well? So we tested this so this is injection of microbeads. You see elevated IOP in mice. And when we systemically inject the antagonist, you see that the IOP drops like a rock and stays down for as long as we keep injecting the antagonist every couple times a day. So, in other words, not only is TRPV4 expressed in the retina, it is also expressed in the front of the eye, and it's regulating IOP. Why is this fascinating? Because this would be a way to treat both at the same time, regulate IOP and neuroprotection. So we can get even stronger effect when we intraocularly inject the antagonist, and you see this lowering lasts for days. We also designed eye drops here at the University of Utah, and these are also effective, lasting for a day or two, so better than current eye drops, you can say. So the important question now is, where is this channel in front of the eye? Is it in the ciliary body, which produces the fluid, or is it in the trabecular meshwork or the maxillary muscle that mediate the outflow? And you see that trabecular meshwork is much more important, because the higher you go with IOP, the more load is going through the trabecular meshwork. Unfortunately, most of the current glaucoma drugs are targeting the uveolar scleral component. So there has been a very strong push of looking at trabecular targets. So we published 2 papers this year showing that it's expressed in both, very strong. And we localized it to non-pigmented epithelial cells, and we did a huge amount of work of the molecular, physiological genetic kind of methods that I will skip over today, just to make point it's expressed in both. But for various reasons, we think the trabecular component is more important. So when we do so-called pressure clamp studies, we see that trabecular meshwork cells are highly mechanosensitive. So the ramps of pressure in both directions induce currents, inward currents. And when we stretch the cells, we see calcium increases that are blocked by the TRPV4 antagonist. These increases are dose dependent. This is statistics. But what is really beautiful, and here we were saved by a collaborator who can mimic the conventional outflow in nanofabricated devices that have been populated with trabecular meshwork cells. You can perfuse through that, and this has been shown exhaustively by them to be perhaps one of the best in vitro models for conventional outflow. So basically, when we do that, we find that the antagonist is highly effective in increasing the conventional outflow facility. So this would be really one of the first drugs that might be targeting the conventional outflow. If you look at the pressure, perfused pressure, on the other hand, the agonist increases it a lot. So this means that the pores in this nano device are much smaller because of activation of this channel. This is exactly what happens in humans. When you increase the pressure, the trabecular meshwork cells become stiffer, the cytoskeleton, extracellular matrix become upregulated. This increases the contractility, which further increases IOP. So is this the case in terms of TRPV4 channels? The answer is yes, because we can stretch trabecular meshwork, and you see the actin cytoskeleton and the focal adhesions get upregulated like crazy. So we can mimic what has been shown in human primate and animal glaucoma at the molecular level. So we also looked at these nano device conventional outflow models, and we see that the agonist, TRPV4 agonist itself, can reproduce the upregulation of actin and upregulation of extracellular matrix, and this is highly suppressed in the presence of these TRPV4 antagonists. So the model here is that increasing pressure in front of the eye imposes some kind of a mechanical stress that activates TRPV4 channels, leading to increased stiffening of these cells and contractility, which increases outflow resistance and maintains or increases elevated IOP. So what we're doing currently is we are nailing down the very kind of specific components of the cytoskeletal mechanism that link the internal cell cytoskeleton to the focal adhesions and to extracellular matrix. Some things go up during pressure and stress, some things go down. And another fascinating approach that we are using is we use FRET probes, so fluorescent probes that function as force sensors. So basically they are stretch sensitive, and by looking at change in fluorescence, we can tell how much load is imposed on the cell as we are pressing or as we are doing any kind of manipulation. As you can see here, the load or the strain is mainly at the focal adhesions. So this is, nobody has done really before that in the eye or the brain. So this is really exciting way to go forward. So I won't go into this, but this is what we're thinking is the mechanism that regulates the outflow resistance at the level of trabecular meshwork cells. It involves CYP450 enzymes. It involves calcium and gene expression, and we have data for pretty much all of these components here. Now, to conclude, we think that IOP, the TRPV4 channels regulate IOP at both inflow and outflow levels, although we think that the outflow component is probably more important. We think that they also regulate the remodeling that happens during mechanical stress in glaucoma, at the level of ganglion cells, the neurons, and glia. I didn't talk about microglia. They also have these for channels, and they also are very stress sensitive. So, and combined, these events together function to induce the phenotype that we call the glaucoma screen. What is very interesting, if you look at this has very interesting parallels to the neuropathic pain paradigms that we see in other sort of force or mechanical dependent paradigms we see across the body, but they have different names, so we think they're different diseases, so to speak. So if I have just a couple of more minutes, I will tell you about some of our unpublished work, which I think is very fascinating as well. Because I told you about endothelial cells that may be involved in glaucoma, but they also form the blood-retinal barrier and are critical for all kinds of other diseases, from diabetes to ischemia and retinopathy of prematurity, macular degeneration, and so on. So we found that they express TRPV4. Oh, yeah, first of all, just to show you, this is endothelial cell. It is enveloped by a parasite in the case of microvasculature, or smooth muscle cell in arteries, and that is shadowed by the end feet of neuroglial cells. So this is called a gliovascular unit that is really responsible for the brain and for the retina to be able to function in any way. And when we immunostain for TRPV4, we see that endothelial cells very, very strongly express TRPV4 channels. And in fact, what is interesting is that they're expressed in the microvascular endothelial, retinal endothelial cells, but not in chordae capillaris. So different microvascular beds have very different calcium or ion channel signatures, which we have explored, but I don't have the time, obviously, to talk about. One thing which is interesting is that the calcium increases in these cells are enormous. They are tenfold more sensitive to any other cells that we have ever investigated. When we look at the currents, when we look at the calcium. So they really, really, really care about mechanical stimulation. So we, in collaboration with Dean Lee, here at the University of Utah, we can look at now a model of blood-retinal barrier by doing high-profile impedance studies in monolayers of these microvascular cells. You see, when we use the agonist, there's an enormous increase in permeability, in vascular permeability, just like crazy. So again, suggesting that these cells really care about mechanical stimuli, and the TRPV4 channel is a potentially major regulator of permeability. Now, we nailed down, we believe, the molecular mechanism of this. So the permeability of blood-retinal barrier or the blood-brain barrier is mediated by V-cadherin, beta-catenin complexes and occluding complexes. And we found that TRPV4 agonist triggers a retraction. This is V-cadherin, this is beta-catenin, I believe, or actin. Beta-catenin, a retraction of these complexes towards interior of the cell, which is directly correlated with increased permeability across these intercellular junctions. So again, this is something we are exploring very actively at the moment. And this is kind of the model of this gliovascular unit, because the interesting thing here is that TRPV4 is very strongly expressed in Miller end feet and in the vasculature, and we believe it's regulating and controlling the flow of metabolites and swelling, as well as pressure sensitivity within the retina. Now, when we treat any disease, we don't want to treat just any target within it. We want to choose the targets where many signaling pathways converge, so as to treat several symptoms at the same time. So I propose that in terms of treating glaucoma, TRPV4 is a very convenient and reasonable target, because first of all, it's expressed exactly in cell types that are most effective in glaucoma. It is associated with transduction introduction of mechanical forces and stimuli that are highly relevant for glaucoma. And by treating this or targeting this channel, we believe we could alleviate a lot of the phenotype that is associated with the disease. Here, I would just like to mention that most of these diseases that I plotted here, I plotted because I already knew they are associated with TRPV4 dysfunction. Some of them with TRPV4 mutations, which are associated with pathological load bearing, with sensory motor neuropathies, with neuropathic pain. I don't know about intracranial hypertension, but I would not be surprised, especially because they interact with alpha-4, it's very strong. So basically, we think, or I'm thinking, that if glaucoma is just an ocular version of neuropathic pain, so to speak, it's a kind of a semantic switch that perhaps we could make, especially once we better characterize what is going on in terms of signaling and symptomology. So TAM Form was involved in pretty much all the aspects of the work that I was talking about today, and she is really spearheading the endothelial project and driving with her ideas. Everything was started by Dan Riskamp, who was a grad student in the lab, and he kind of started this train rolling. Sarah is working on microglia. Oleg and Maxime are electrophysiologists who have done absolutely spectacular work on mechanical transduction. I think this is really, in terms of neuronal stuff, something that nobody has done, even in brain neurons, stuff that we are doing right now. Andrea is doing phenomenal work now on steroid glaucoma that I didn't talk about. Andrea, where are you? Here she is. So, and Andrew has been working on aquaporins and swelling and stretch assays. And I have to mention here in public Dr. Olson, because I am a photoreceptor guy, and I wouldn't be talking about glaucoma if it wasn't conversations and support from Randy. So who basically said, go ahead to some of the crazier ideas that I had. And without that, those crazy ideas would go to nothing. So I had no support when I started those studies, and with support from Randy, this actually started to roll. So thank you.
Thank you. So, David, obviously, I'm extremely excited about your discoveries and what's ongoing. And I also want to point out to everybody here, this is an example of why we need meetings like this. All too often we're in silos and we only talk to each other. We go on about that politically as well if we want to. We'll just start with the science. And it turned out that David picked this up in a calcium channel meet. It had nothing to do with ophthalmology. And so we've got to be willing to listen and understand outside our normal field. And this whole line would move forward. I think he's on something incredibly important. It's now moved to a really important partnership with organic chemistry and working on better antagonists and ones that we need to be there. And I hope it will be in clinical trials in the very near future. But all the work done today suggests that this is critical, not just for glaucoma, but a host of different conditions. And so congratulations, David, taking this from nothing to a very exciting field.
Thank you. Exciting things. Well, our next speaker is Brian Jones, and he's a research associate professor. And if you think that was cool,
So, I'm not going to talk, we don't do a lot of translational work per se. I'm not going to share a whole lot with you about any active translational work the work that is going on has massive implications for a lot of translational work that's actively going on right now around the world. So, thank you. Better? So we study the retina at the back of the eye. Let you guys are sort of used to this view. We're interested in what happens in two diseases, retinitis pigmentosa and age-related macular degeneration. This is sort of the classic view of RP. We're going to sort of look at the histology a bit more. If you sort of zoom in, this is a backlit view from behind the globe, sort of illuminating the retina and these pigmented bone spicules. If you look carefully, you can see a couple of ganglion cells there. This is sort of another view up close, another patient with RP, hypopigmentation, but again, a lot of these pigmented bone spicules. And if you look at these pigmented bone spicules, you have to sort of start wondering about the histology. So there are some tools that we can use clinically, OCT in this case, and it sort of can give you a view. This is an early case of RP, of what's going on in the retina, but really the gold standard is histology. So the important thing with histology, we're going to look at photoreceptors sticking up in these samples. It looks obvious now, but in a minute it'll get a little more complicated. So the important thing to remember is a mammalian has about 70 kinds of cells, right? And so if you start making changes to the numbers of cells and their connections, it turns out it has a lot of implications into how information is actually processed. So light comes through, hits the photoreceptors at the back, the photoreceptors do detection, and then transduce those signals through a set of circuitries that do luminance detection, contrast detection, movement detection, a lot of sort of visual primitives before sending those data out to higher structures in cortex and subcortex for further analysis. The problem is, in disease like RP, AMD, these photoreceptors become compromised. And a lot of the community for a long time presumed that when these die, this structure or these structures romantically hang out and wait to be rescued. And so we've been beating this drum for about a decade and using animal models. And so what we can do with animal models that we can't do very well with humans is identify the gene, give them the disease gene, and then track the disease as it progresses through animal models. This is a mouse retina over 700 days as it's remodeling. So the photoreceptors get stressed, the photoreceptor outer segments shrink, photoreceptor cell bodies start to die, bipolar cells and amacrine cells start to die and move and rewire, ganglion cells migrate into the amacrine cell layer, and the whole topology of the retina changes. So this happens in every single animal model that we've looked at. Rats, mice, pigs. There's a very expensive transgenic pig that's available from Louisville. The last pig that I handled and took the eyes from was about $100,000 from birth to where we harvested the eyes. We have a rabbit model now that's much more affordable, smaller. It's still a large eye model. It's about 2/3 the size of a human eye, and it turns out it's a perfect mimic for autosomal dominant RP in humans. But regardless, all of those animal models do this. And we've been hammering on this for years and are distressed by the number of human clinical trials that are going forward in bionics and biologicals and gene therapy and optogenetics that aren't taking this real biology into account. So we started collecting human tissues. This is a normal human retina. Actually, it's probably early AMD. It did not have a diagnosis when we got it. But the reason I say it's probably early AMD is this is one of the first things that we see in AMD. So this is retinal pigment epithelium up here. And in normal, healthy retinal pigment epithelium, you shouldn't see any color variability in this particular label. So this particular label is actually 3 separate labels. It's taurine, the small molecule taurine, small molecule glutamine, the small molecule glutathione that are assigned to red, green, and blue color channels. And that gives us this sort of view where we can visualize Mueller cells in gold, and then photoreceptors and some of the other cells. But it also allows us to see nicely the RPE here. And as I'll show you in a minute, in normal healthy tissue, you don't see any variability there. And we think that this is actually the first indication of disease implications in dry AMD, at least. Here's another view where we changed the labels. This is GABA in the red color channel, glycine in the green color channel, glutamate in the blue color channel. This allows us to see excitatory and inhibitory neurons in here. So the important thing with this normal human retina is, even though there are some indications of disease, the overall topology is intact. Photoreceptors out here, you can see cone photoreceptors standing up here. There's the autonuclear layer, interplexiform layer, some inhibitory amacrine cells, and on-cone bipolar cells here, and the ganglion cells down there with some vascular elements. Here's a normal, happy primate retina. Turns out we can get primate tissues, non-human primate tissues, faster than we can get human tissues. This was collected within about 20 minutes post-mortem, and a lot of the signals are a little fresher. But the important thing here is to look at the RPE. So this signature, this fingerprint, is what normal RPE. And you can profile all the RPE cells in a normal human, and you'll get absolutely this. Again, so if you keep this in mind, normal healthy retina, ganglion cells down here, is the optic fiber layer down there. Again, we can switch it. This is the view that allows us to see excitatory and inhibitory neurons. But again, normal lamination, everything looks really, really, really happy and healthy. This is central retina from a person with RP, about 74 years old, NLP, no visual percepts. The interesting thing is the IPL in this particular guy was largely intact. There are almost there's no rod photoreceptors. There are a few cone photoreceptors, and this is actually important. We'll come back to in a minute. And this is GABA glycine glutamate labeling. If we can get the tissue fresh enough, it's still alive. And we can do some experiments. We have a molecule called 1-amino-4-guanidobutane. It's a non-selective glutamate channel marker. So basically put the retina in AGP and stimulate the retina with pharmacologics like canic acid, NMDA, or with light. In this case, light wouldn't do much. And glutamate channels open up, and AGP flows into these channels. And so we can get a visual picture for which neurons have been activated. So we basically recorded from every single neuron in this tissue. The more green in a particular cell, the more AGP that's flowed in. Right? So we can do this AGP labeling in addition to our other small molecular markers. And what we can do is we can generate a classification mask. And so what we can do is we can find all the horizontal cells, and we can find all the ganglion cells, and the inhibitory amacrine, glycinergic, GABAergic amacrine cells, and the different bipolar cell classes here. And so the interesting thing here is in normal mammalian retina, the bipolar cell classes, your on-cone bipolars, your off bipolars, and your rod bipolars, you should have about 33% of each. Right? So there should be equal numbers of equal ratios of those bipolar cells. The first thing that starts happening in RP, and we've seen this in animal models, and now we've confirmed it with humans, is that these ratios change. And what you see is you see the on-cone bipolar cells dramatically reduce in number, and the off bipolar cells dramatically increase in number. So in this particular case, they've effectively doubled. And that's interesting. Even though the topology of the retina is intact, you can still see some cone photoreceptors up here. It turns out, as long as cones are present, the overall topology of the retina is maintained. As we'll see in a minute, when cones disappear, that sort of restraint disappears. So here's another region of retina, and this is the YGE. We're going to look at TQE, just to slide that down. So again, taurine, glutamine, glutamate, GABA, glycine, glutamate, allowing us. So these are the same cells that you're seeing in both. We're just visualizing them differently so that we can see different things. And the first thing to look at is we're starting to get, so here's a retinal pigment epithelium cell that's died in this particular case. And then we can look down here. And this is actually very interesting. We have a grad student in the lab now. She's chasing this problem aggressively. So normally Mueller cells should all be the same color too. They all have the same small molecular fingerprint. And interestingly, this is the case across species. So birds, turtles, fish, mammals, this sort of signature, this mammalian Mueller cell signature, the job that Mueller cells do in metabolic space is very robustly maintained across evolution. But what starts happening when retinas get stressed is we start seeing this variability in Mueller cells. So the metabolism in Mueller cells starts altering, and it starts stretching that sort of metabolic envelope. And they start doing some very different things. And we can start visualizing that here. So in these particular Mueller cell columns, there's more taurine in them, and so they're going more red than the regular sort of looking Mueller cells here. This is also true on the ultrastructural level. If we look at the ultrastructural data that I'm not going to show here, there's lots of protein changes that start happening as well. We can see that with electron microscopy. If we look at these boxes, so this one is just to show you that there are some common photoreceptors, even though they're sort of nubbins. The nubbin of the outer segment, the outer segment is still left, but it's helping to maintain the overall topology of the retina. This box we're going to sort of zoom in on here. And the important thing here is to look at sort of these fine processes that are coming up from glycinergic ganglion cells. So normally glycinergic ganglion cells, the cell body's here, and the processes come down to connect in this interplexiform layer down here. In this case, they're starting to project up in the wrong direction. Right? We actually saw this in animal models first, but what they start doing is when you effectively deafferent the retina, when you remove photoreceptor input, all the cells downstream have two choices. They can either die, which a lot of them do, or they start sprouting. And they start sprouting these processes, and they start talking to other neurons. And they do this likely to maintain calcium regulation, calcium signaling, and gene regulation. And there may be some other mechanisms for that, but this is a very common finding, this sort of sprouting. It turns out if you look at the ultrastructure, there are synapses in these sprouts. So these are not sort of quiet processes, they're active processes where these cells are finding other partners that they shouldn't be talking to, but they do. Things can get really weird. These are amacrine cells in the subretinal space. So these are cells that have migrated up from where they normally live, and they're now taking up residence out here. So in addition to sort of the sprouts, the cell bodies can migrate and go in weird places. And then we've taken a punch here. So this is a 3 millimeter punch from human RP. And so look at the red stripe here. We basically took a histologic slice right out of there. And we wanted to look at far periphery retina. So the idea is that the data that I showed you before was sort of more central retina. And because RP is sort of a periphery to central disease, we wanted to see how bad it can get. So we looked at OCT, not a whole lot of OCT signal, not a whole lot to see. But if we look at the YGE, there's basically a lot of vascular components. The vascular components have sort of become hypertrophic. There's almost nothing left of a normal retina. There is nothing to see, which is why we couldn't see it in RCT. There are some Mueller glia elements here. Turns out there's some astrocytic elements from some other work that Becca Pfeiffer, the grad student I told you about, is working on chasing. But almost all the ganglion cells are gone. A lot of the GABAergic inhibitory neurons are gone. Glycinergic ganglion cells are still left. Most of the bipolar cell population is gone, and all of the bipolar cells are effectively gone. This is, for all intents and purposes, a dead retina, and there's no rescuing this. These are other mappings. This is taurine and glutamate to show you sort of the glial components that are still there. Here's some proteins, GFAP, CRLBP, and arginine. We're sort of trying to look at some protein, which proteins are still left. Small molecules change much more rapidly than the proteins do. And this is a probe for rhodopsin. So normally you should be able to see nice pretty photoreceptors up here. The only opsins that we can see are sort of trapped in and around these vascular elements that are probably sucked down and fail to metabolize. So this is another sort of stretch out in peripheral retina. Again, just to show you how bad things can get. So this is a little distance away from that red stripe that we showed you earlier. And again, this is what a normal retina and normal retinal thing should look like. So if you sort of take this bottom edge, this vitreal edge down here, and sort of go up, this is where the diseased retina stops, and that's how much further it should go. So the idea is that in RP at least, this is completely scrambled. And this is sort of if we took a horizontal section through the retina, through the Mueller cell infeed. So if we section into the screen just a little bit more, we'd be into the vitreous. This is just before we get to the vitreous, and so these are all the Mueller cell infeed. The normal, happy, healthy tissue, you should see this nice sort of mosaic tiles, but it should all be the same signal. This is clearly disrupted. There's a lot of stretching going on. There's some vascular elements that are sort of pushing in, and the signatures are all different, right? So this is glutamine synthetase, taurine, and glutamine in red, green, and blue. And again, this is showing you that there's effectively metabolic chaos in Mueller cells. And this is sort of another question. At what point, so Mueller cells are really important for maintaining normal homeostasis in the retina. They help exchange small molecular components and recycle a lot of components for neurotransmitters. And so the question then arises, how far can you sort of push the metabolism in Mueller cells and expect retinas to be able to function normally? This is another mapping of taurine and glutamine, just to show you again the diversity that's pretty crazy. So the other recent paper that we just published was AMD. So this is sort of the classic view that a lot of you guys look at. Nice sort of pretty drusen fundoscopy. We can sort of zoom in again, and we can see these nice sort of pretty drusen form and some sort of pigmented structures here. Here's some histology. There's some knife cuts through here. I apologize. But again, let me sort of direct you to the RPE. Again, this sort of tiled appearance. It should be absolutely smooth and confluent signatures. There's a small groove right there. This is very early. This is taurine glycine refinement mapping. And this was just looking at taurine. So this is just looking at the RPE here. So here's the vascular choroid, and here's some photoreceptor outer segments. This was a cool image because it shows you the tiling that goes on. So each one of these is separate retinal pigment epithelium cells, right? And normally they're coupled, so there are gap junctions between them. And that allows the small molecular signals to flow in between them. And that's why the signature is absolutely uniform in normal healthy tissue. What's happened is the gap junctions have become uncoupled, and each one of these cells is doing their own thing. We suspect that leads to dysfunction, and so what we're starting to see, we don't quite know what they are, but these are taurine-rich deposits, subretinal, subdrusen components. Who knows, actually? There's some argument. When we published this paper, we actually argued normally turns over photoreceptor or neurotransmitter molecules goes away. So the translational component comes because a lot of people are looking at ways to sort of intervene. And bionics is one of the big sort of approaches. So there's a couple of ways to do bionics. One, you can sort of put a bionic implant underneath the retina. You can surgically detach the retina, slip the bionic implant in with the idea that you stimulate the surviving retina. The more diverse, the more successful in terms of sort of the market penetration seems to be the epiretinal implants. They put them down. The idea is to stimulate the ganglion cells. The problem is there's a field effect, and so you have to sort of ask yourself, which cell populations are you stimulating? Even if you say say, okay, well, we're only locally stimulating the ganglion cells, it's still a problem. There are also 12 to 20 channels of outflow from ganglion cells and it just doesn't go to the visual cortex, it goes to subcortical areas, it goes to superior colliculus, LGN, a lot of different places. So you're sort of stimulating these ganglion cells indiscriminately in a lot of cases. Well, in all cases, when you're using bionic implants. There are some other approaches to do optogenetics. We've done some of these studies where you can take a virus and engineer in an opsin. Basically, if photoreceptors disappear, you can put the opsin in surviving cells. And the idea is the light comes into the retina and hits these cells that have been genetically transduced so that you can express the opsin, and then the thinking is that these cells then stimulate surviving retina. The massive assumption here is that once you do this, that the retina will stop degenerating. And it turns out we did some early experiments in retinal remodeling, this process that we call this sort of plasticity. It's a freight train. And because you put a little bicycle in front of a freight train, it doesn't stop the freight train. The freight train is still going down the track, right? So we intervened with optogenetics, and we waited and tracked the animals for a couple more years, and the retinas just went to hell, even with the optogenetic therapies. So, but the assumption is that you can stimulate bipolar cells, you can stimulate amacrine cells, in this case, two amacrine cells, or you can put in optogenetics in ganglion cells. And there's a lot of very cool evidence that this works. In fact, the first guy that did it really got kind of jerked around. This guy Pan at Wayne State University was the first to actually show that you could do optogenetic therapy in retinas, and he largely got ignored. He presented that at ARVO in 2005, and it was the single coolest thing I saw that year at ARVO. And Stanford is a little better at promoting their people, and there's some very talented people. Actually, Ed Boyden is wonderful. He's now at MIT, and Carl Disseroff really got most of the fame for actually doing this optogenetically. And there are a lot of reasons why that happened, but Pan was the first guy to actually do this. So the problem with all this is, even if you do successfully transduce these cells, the cells die, the cells rewire, and this circuitry substrate changes. And so then the question is, how bad does it change? And the other main mission of our lab, sort of Robert Mark's baby, was that we study how the normal retina is wired. So these are two A2 amacrine cells, and it turns out there's a very specific structure, there are very specific synapses and gap junctions that all of these cells make with other populations of cells in the retina. And it's very tightly constrained, the cell partners that they normally partner with. And so it turns out we can identify these, actually, we can go in and pick in our connectomics volume, we can pick synapses and gap junctions and actually visualize them with electron microscopy, and reconstruct this and make these beautiful sort of figures, and then we can sort of make these connection diagrams. So here's one of those A2 amacrine cells here, and we can start mapping out raw bipolar cell input onto it. There's another GABAergic amacrine cell input, and we can sort of start mapping this out. The trick is, it gets really complicated, right? So this is just two synaptic hops away from that A2 amacrine cell. And so if you start asking yourself, in retinal degeneration, which one of these connections gets broken, and how many of them can you break and still expect normal retinal signal processing to occur? That's kind of where we're at now. We're trying to figure out what goes wrong where, and then there's a lot of modeling that can be done to try and figure out how bad can you get, at what point can you no longer intervene with bionic or biological approaches. I'll just wrap this up real quick. So we've done some bionic work with people, we've done some optogenetics work, and we've done some cell-based work. Turns out underneath bionics, remodeling is accelerated in a lot of these cases, and to genetics, like, as I told you, the remodeling progress just proceeds. It just keeps going down the track. We've done some cell transplants. Turns out remodeling is accelerated in transplant. So we haven't done a lot of genetics yet. There's some other experiments we'd love to do with Wolfgang, and the question's open there. The basic take-home message is that there's a lot of rules that are happening in retina, and we need to understand what the rules are. And this is the lab. These are some of our collaborators, and funding. So thank you.
So Brian, did you see the National Geographic end of the
I
class?
did.
And then there's a couple of clinical things come along. The idea seems to persist. It's like a light socket. You just got to plug it in. The only issue is how many points of contact you can make. And yet your work is so overwhelming, and it's not. I mean, others now followed and confirmed. Why do you think there is this? Is it head in the sand? I don't want to think this is happening.
couple of companies, and I apologize, I can't really disclose much about them because some of the work still hasn't been published yet, so I can't talk about it. I'd have to kill you first. But there are some ways that are not quite as complicated as that. And so the idea is you put this base unit in the capsular bag, and you can take the optic out and adjust it. Now, in children, that would be very good, especially infants that you're doing cataract surgery on. You could put it in there, and then as the child's eyes grows and you have to change it, you just change the optic without disturbing the lens capsular bag. So I think that's a pretty exciting technology for the future. Now, I just wanted to show some of these. There's some wild ideas. These guys have basically a little piston system here that you screw in and screw out. And so if you want to adjust it, you go in with a micro instrument and basically screw it down or screw it back up. And so interesting way of adjusting an IOL power. And they actually did some initial human studies on this lens. And they said they could adjust it without any kind of damage to the eye itself. So interesting idea. Now this one is repeatedly adjustable, and the idea is that you actually screw the optic in and then unscrew it. And so again, but these are all invasive. Now that's the problem. They're all very invasive techniques. And lastly, these guys actually hooked a magnet to it. So they magnetize the material in there, and the idea is that you use the magnet to unscrew it, and you can change the power when you do it that way. So wild idea. Now, what's getting more exciting now is the application of using the femtosecond laser to change the surface of the IOL. And we're just starting now to do some work with this particular company. It doesn't take much to change the power on the surface of an IOL. In fact, we're talking micron level changes. And the idea is if you use the femtosecond laser, and Dr. Beal is the doctor who's talked about this, and Aaron Scientific is the company that's doing this. And the idea is you change the molecular structure on the very surface, and you can actually change the power. And the idea with this is you can actually change it multiple times, and you can change it in a lens that's already in the eye. So this is not a particular lens you put in the eye. This technology would be something that you could use in all implant materials. And so what's exciting about this is you could have a lens already in the eye and you can change the power. Now, if you wanted to think a little bit outside the box, there's all kinds of ideas that you could do. You could put a multifocal pattern on there, and then if the patient dislikes it and has dysphotopsis and doesn't like it, you just erase it. Exactly, and I know I'm exaggerating here, but this is something that can really be done. And so this is pretty fascinating technology, and so we're just beginning to do some early studies in little patients on this particular technology. But I think this is very exciting for the future, because how many people do we have that we like to do that fine-tuning of their implant power once it's already in the eye? And here they could again do some phase warping technology, put a multifocal pattern on there, try to get people to have some near vision and some distance vision. Well, what is there that's available now that's in phase 3, and so it's almost available now? The light adjustable lens. And this is an IOL that you can actually, again, change the power of the lens once it's inside the eye. But the problem is you can't just apply this to a lens that's already in there. It has to be a specialized lens that goes in the first place. Now, it's a very interesting idea, and if you're going to try to change the power and add power in the center of the lens, you can get a hyperopic correction here. If you want to do a myopic correction, you shine it in the periphery of the lens. Now, let me show you how this works. So this has a partially polymerized silicone with some little moieties at the end of the side chains, that when you shine UV light on there, they will then further cross-link. And so you shine the light in the center, these little side chains will then cross-link, and then this creates a diffusion gradient. So over about 24 hours, the unpolymerized material from the periphery will then flow into the center of the lens, and as that flows in, that will change the curvature on the surface. And so as that flows in, that diffusion gradient, this really will happen in about 24 hours. You can change it, then once you're happy with the change that you've got, you lock it in, and you shine the UV light on the entire IOL, and when you do that, that locks everything in. But they're working on trying to make it so that it can be continually changed with time. Now this is now in phase 3, and we're hoping to have it out. This is again one of these technologies where we started doing work with them in 2002. And the idea was this is going to be ready always the 3rd quarter of like the next year. And so this has been for 14 years now, but the phase 3 studies are almost done, and so we may have this available sometime soon. So this is potentially exciting again in the group of patients, especially people who've had previous refractive surgery where you've got some refractive surprises. But the other thing that you can do with this technology is you can change the delivery of how the laser puts the pattern on there. So you can actually get a astigmatism correction, and we've done that again in little patients. You can even go ahead and make it so that it does some wavefront corrections on there. So just for fun, we did a tetrafoil pattern on here, and that kind of looks like the, it looks kind of like those Dippin' Doritos that you have, during the Super Bowl. And so the idea is you could do all kinds of things on there. So you can measure the refractive error within the patient's entire visual system, and then put that something that's going to neutralize that right on the IOL. And so you can do wavefront corrections, astigmatic corrections. Again, the idea of the femtosecond laser, you could theoretically put a multifocal pattern on here, see how the patient does with it before you lock it in, and then just erase it when it's done. So again, pretty good potential for things that you can do with this particular technology with the adjustments that are made. So in conclusion, when we look at adjustable IOLs, I think that these are very exciting until our measurements get perfect, but also even when our measurements are perfect, sometimes patients are just never happy. You can have someone who maybe you made them a monovision, and they just can't adjust to it, or very unhappy. So the idea with some of these adjustable lens technologies is you can change that later, or in the ones where you actually have a base unit in place and remove the optic. For example, children, as they grow, you can go ahead and you can change it, or as people grow, you can change it. So I think this is very exciting technology, and of course the Calhoun's the furthest one along, but there's several others that we're looking into. So this is hopefully where I'm going to be tomorrow morning, and so thank you for your attention. I'll be happy to take any questions.
So, the word I'm hearing from Calhoun is either fourth quarter this year or first quarter next year. But I do think it's real close. I think indeed that may happen. But it's interesting they waited so long. I just think that refractive index shaping may just crumble.
That's no problem. If you've got a technology that doesn't get out there soon enough, someone may leapfrog you, and that's.
And they can work in any material, as you mentioned. I mean, it looks like correction up to almost 3 diopters, plus or minus, which covers most of the curve. We're talking about cylinder the same amount, multifocal, and you can also do hyper and spheric, and you've got multiple shots on the same lens. It looks like maybe you can do 5 times in a lifetime. So if you could imagine, you go in rather than you're buying a new pair of glasses, you've got an intraocular lens, and you sit there and you say, no, we got to get it trued up. Well, you hit it, there's a treatment is down just to a few seconds, boom, and it's instantaneous as well. And the FDA approval process may be surprisingly easy because this is really a laser treatment into the eye.
It is. It's not a new lens. It's not a new polymer. It's not a new material, and it's not a new laser. I mean, it's basically a femtosecond laser.
It could happen pretty fast, but it is. I think it's one of those truly seminal changing technologies. It would be really important for all of us in the field, where you come in and you get this brief refractive procedure. It's in order to keep the eye doesn't move. You're going to have to use a suction, so it's going to be a lot like either doing a femtosecond flap cut or a laser brush. You're going to have to get used to do that, but once you have it, you've got it locked in, and the whole thing is just a matter of a few seconds, and it's instantaneous.
Well, if my fellows are still here, at this stage, it's not quite instantaneous. And so as the fellows will attest, our first attempt at doing these took, 9 hours? So, I mean, it was not quite instantaneous.
But the actual laser part was pretty fast.
Well, not even that. So it
took a while to get it.
Still got a few little procedures to work out. But I think it's a work in progress, and I think it's pretty exciting.
Theoretically, they can get it down where it's like 7, 8, 9 seconds.
Exactly. So I think this is pretty exciting technology. All right, so let's just continue ahead. All right, so next we're going to have Ning Tian. He's a research
research. So I'm going to show you some preliminary results we got for our disease-related research. Our research has been focused on retinal ganglion cells. For most of you, I guess everybody probably understand that, but I'm still going to go through this quickly. So retinal ganglion cells is the only cell type connected eye to the brain, so it's the only output neuron. And the retinal ganglion cells are very vulnerable in many diseases, including like a glaucoma, which is a very common disease, and also like a brain injuries, someone has a car accident, and the brain get hit on the dashboard, and the optic nerve can be injured there, and the swollen optic nerve or bone fracturing behind the eye can cause optic nerve injury. And this study of the project is supported by the VA grant because a lot of soldiers in the battlefield, and they have a roadside bomb blast to the brain can cause the optic nerve injury very commonly. So the question we're interested in is that when you look at those any of the disease problem caused retinal ganglion cell injury, from those ganglion cells are actually there are many types of subtype of ganglion cells. They respond to those pathological insult very differently. Some cells are much easier to be injured or damaged or killed, and some cells are much tougher and more resistant to those diseases. So we're trying to figure out what are the reasons or the mechanism which control the vulnerability of those ganglion cells, so hopefully to find a way actually enhance the resistance of retinal ganglion cells towards different injuries. So that's the purpose. So this is just to show the examples. So when we try to study how ganglion cell dies, we want to figure out the process of their death. So if these are the pictures from the live animal or from mice. So we use the transgenic mouse, we can express the fluorescent proteins in the ganglion cells, so we can actually watch the cell, the morphology, every day for a long time period. So this is the example when we put those glutamate injected into the eye. So glutamate is a commonly excitatory neurotransmitter naturally. So in our brain and our retinas, most of the excitatory cells actually release glutamate as a neurotransmitter. But when they release too much of it, it causes toxicity. We call it excitotoxicity. So those happen if someone has a brain injury. You have the primary cell death, and those dead cells release a lot of glutamate into the adjacent cells and cause those cells the secondary deaths of the cells around the primary injury. So glutamate toxicity is a very, very common cause. So in the hospital, in emergency room, about 40% of the patients, brain injury patients, die due to the secondary injury, not the primary injury. So glutamate toxicity is a very, very important issue. But in some people even believe that glutamate toxicity is the cause of, or partially of the aspect that cause the ganglion cell death in glaucoma. Because sometimes, particularly if angle-close glaucoma cause immediate IOP increase, cause a lot of cell death and cause secondary cell glutamate toxicity. Okay, so when we inject the glutamate into the eye, we look at how the cell die. So you can tell before the injection, the ganglion cells have healthy dendrites. And then just 10 minutes after that, the dendrites start to become segmented. And about 3 hours after that, you lose like 80–90% of dendrites, and 6 hours of that, the cell loses all the dendrites, become soft. So when we look at the cell death process, what we found is, and we use the capsid-3 is a cell death molecule, and when the cells start to synthesize capsid-3, which means the cells in the process of dying. So, and then we compare the time course of the disappear of the fluorescent positive dendrites. We found the ganglion cells always lose their dendrites completely before they starting the cell death process. So it sounds like loss of a ganglion cell, loss of dendrites is a condition for the cell die, or is the earlier stage of the cell death. So, but with some of the cells, they lose their dendrites completely. They can keep alive for several days in this condition. So what actually keep them not dying without dendrites, or can we actually promote them to regrow dendrites? And then what that save them from dying? So it's a question we're trying to study on that. So that's one example. So another example is this. This is actually the optic nerve crash in the live animal. So we identify these cells, and then we go to the back of the eye, use the forceps, just mechanically crash the optic nerve on the live animal, and then we watch the cells, see how far they're going to die, how they're going to die. Well, you can see it's like 31 hours after the nerve crash, that same ganglion cell lose all the dendrites, and 4 days later, that cell is gone. Okay, So again, in addition to the glutamate toxicity, mechanical injury of optic nerve, even you injure the axon of the ganglion cells, the cells don't lose their axon. Actually, they lose dendrites first before they die. Okay. And the third example is this. This is even much longer. This is a light-induced cell damage. So we look at a bunch of cells. We use a relatively high intensity laser to just scan out this particular cell, and then we wait like for 13 days. And those cells start to actually lose their dendrites. Dendrites become segmented. And then 14 days later, or 1 day after this, they lose their dendrites, and another 2 days after that, the cell is dead. So it doesn't matter what kind of injury you use. When you injure ganglion cells, they lose dendrites first, and then they die. Okay. So then, as I said before, so if we look at mouse and even human or rabbits, all those mammalians, there are multiple types of ganglion cells, morphologically and physiologically. Okay, and those cells actually respond. So first we want to know, we know the cell responds to disease. Conditions are very different because some cells die sooner than others. And then we want to know, okay, so what are the control mechanisms for the vulnerability? So that's one goal we want to look at. So to characterize the ganglion subtype specific vulnerability, that's one goal. The second goal we want to look at that is when we lose ganglion cells in the retina, and how is that going to affect other cells, even they are not directly injured? Is there any secondary cell death after ganglion cell injury? Okay, and then because that's very important, because if we want to say do the stem cell transplantation to restore the vision, and if you don't have the normal cell morphology or well-being of other cells, even you put in the new ganglion cell in retina, they're not going to function normally, because the whole retina has to function as a network, not individual cells, because the nerve system all function as a network. So that's the second thing. So the third purpose we're doing here is we have some candidates have a neuroprotective capability. So we want to try those chemicals with neuroprotective capability while they actually protect the cells from death. Use the model we're using. And the fourth, well, actually, I reverse that. But the fourth purpose we're doing is we're trying to figure out if there's any genetic approach. We can actually protect the cell by overexpress or downregulate the gene expression to change the cell vulnerability or promote the survival after disease. So animal model what we're using is, as I said before, we use two common models. One is the optic nerve injury by pressure optic nerve, and the second is by injecting glutamate into the eye to cause the glutamate encephalotoxicity. Okay. And then we use transgenic ganglion cells which express fluorescent in this ganglion cell, so we can actually very precisely monitor the structure change of the individual ganglion cells. So we choose three ganglion cell model and another animal mouse model with the amcrine cell specifically express GFP. So we basically have 4 animal models, which this is the alpha ganglion cell. We use one model specifically labeled alpha type cells, and then those 2 other ganglion cells we call either BD ganglion cell and JB cell, and then there's this amcrine cell we call the Stargardt cell. So we just pick up 4 type of cells here to test their vulnerability and their response to disease or the pathological result. So, and then the technique we're using is just look at the cell numbers and then look at cell morphology. And this is an example of our 3-dimensional tracing of a single ganglion cell dendrites. So by looking at the retina, we can actually precisely identify every small branches of dendrites and look at under disease condition how this changes, or if we change the gene expression, how they're changing morphology. Right. So this is the results. First results we're looking at just look at the vulnerability of 3 subtypes of ganglion cells. And look at if we take the retina out, we just put in glutamate on the retina and watch individual cells how fast they can lose their dendrites. Right? What we found is from those 3 subtypes of ganglion cells, the 2 subtypes of them actually lose their dendrites very quickly, but another type, which is a BD cell, they actually dendrites can last for much longer than other 2 types of cells. So prove that on the common cause of cell death with glutamate toxicity, and the ganglion cell, these 3 types of ganglion cells are very different quality. Okay, and this is one point I'm going to touch that later, is if we mutate a gene, intrinsically expressed gene in the ganglion cell, that changes that cell vulnerability from there to here, like other cells. So there's some gene actually control the cell motility, okay? But I will get back to that. So the second model we're using is to do optic nerve crash and then look at how cell die and how it's going to affect the ganglion cell and the embryonic cells. So this is the way we do the surgery. We just anesthetize the mouse and cut the skin a little bit and approach to the optic nerve from the back of the eye, and then put the needle 4 cells behind that, just crush it for 10 seconds. And then when we put the dye into the ganglion cells, and you look at how the dye is being transported along optic nerve, you can say from the crash side, the dye cannot pass that, which confirms the optic nerve is completely crushed at the surgery site. So we know the axon are very badly damaged in that way. Now, then we look at that. So we use the nuclear dye to label all the cells, the cell nucleus in the ganglion cell layer, and then count the number of those cells. So the dye called DADI. So this is the retina, uninjured retina, and this is the retina after optic nerve crash. You can see the blue dots are much smaller. If you're in this is because they're cell dead. So the number of cells is reduced. Now, so when we look at the time course of cell death, you can say, before the crash and after crash, about 7 days crash, we can lose like about 80% of the cells. We will crash hard in that. So that model is very reliable. We know what we're doing. We know how cell die, how far they die, and then we have a very reliable way to evaluate it. So now for ganglion cells, so that's what we know. And then we start looking at another model. Is looking at endocrine cells. So one of the endocrine cells is just interneural actually synapse with the ganglion cell and the bipolar cell in the retina. It's very important for the ganglion cell to have their normal function. All right. So the endocrine cell we're looking here is a transgenic endocrine cell. It expresses green fluorescent protein in those particular cell type. And then if we use antibody to label that cell releases acetylcholine. So we call it cholinergic endocrine cell. Okay. If we use anti-acetylcholine antibody label that, we found this is easier to say those green cells are all red. The red label is the anti-acetylcholine antibody, and the green is the GFP expressed by the cell. What that means is that not all the we call starburst enzymes express the YFP, but all the YFP particles are the starburst endocrine cells. Okay. So we know what cells we are looking at. Then we look at the dendritic structure of the cells. Already. So after eye injury, after ganglion cell injury, what we found here is we get a much lighter crash on the cells. So 10 days later, we only lose about 28 to 30% of ganglion cells. And then in this sense, we don't lose a lot of ganglion cells. We're trying to say, okay, with only 30% of the ganglion cell death, while the endocrine cell be affected immediately. What we found here is actually just like 7 days after crash, even there's no direct injury on endocrine cells, the endocrine cells still die after ganglion cells. Oh no, I'm sorry. Ganglion cell endocrine cell didn't die, but endocrine cells started to lose their dendritic structure. They lose their dendrites by 30% in 7 days after ganglion cell die. So even the cell don't die like this. The cell don't die, the endocrine don't die, but they lose their structure, dendritic structure very quickly in that way. So that's the conclusion about that. Then we start to look at it. When we have those ganglion cell deaths by glutamate toxicity, can we protect them from those injuries? So what we tried is a growth factor agonist. So we inject those drugs or chemical into the eye, and then either crush the optic nerve or co-inject those glutamate into the eye to cause the toxicity, and then count the cell numbers if they still cause the cell death. What we found here is the drug we're giving cannot completely protect the cell from dying, but those drugs can protect it for the glutamate toxicity induced death by reducing it by 24%. We go from here a negative effect. So, but when we look at optic nerve crash, and that same drug has no effect at all. So, which means even those cells die, looks like in the same way they die, but when you put it on the neuron protective drug there, the drug can protect the cell from some causes, but not other causes. All right. So this is the same slide as I pointed to you before. So we're trying to look at if there's any genetic way we can actually find out that the molecules expressed by cell per se control the cell death. If we manipulate the activity of the gene expression, can we protect the cells? So the first thing to do is to find, is there any gene actually can control the cell death, which we found one gene for that particular cell. So this is before the knockout of the gene expression, and the cell is very resistant to glutamine toxicity. But when you look at the knockout, which is the triangle red, which is here, so when we knock out the gene expression in that particular cell, and then we put the glutamine on the retina, we see that cell is no longer resistant to the glutamine toxicity. So we're working on the process. So this is actually, when we knock out the gene expression, which means we inactivate gene activity in the cell. So the next step will be, if we all activate the gene expression in the cell, can we protect the cell? And then we're working on that, and we don't have results yet. So this is the conclusion. So ganglion cell loses dendrites before cell death with all kinds of various pathological insulting. So far we have tested. And the cell type specific transgenic mouse model is provided a very powerful tool for us to actually look at single cell structure and in vivo time course of cell death. And some of those neuroprotection agents which can protect the ganglion cell from death for some causes but not other causes. So the cell response to the same agent or chemical seems very well depends on what's the cost to cause the cell death. And then seems like we find a gene which could potentially help us protect cell in the future if we can activate them before or during cell death. So this work is most of the work is by an MD PhD student Xavier, and then there are visitor scholar Hong Yu, and there are two other people which are not in the picture. Thank you. Oh, I'm sorry. Before you guys ask a question, I have to say these are supported by multiple agents for this.
Questions?
So, Ning, are other cell types affected when ganglion cells die besides amacrine cells?
Which we don't know actually at this time. So, which is very good, which is the question we really want to know. I mean, people know that if the photoreceptor die, it comes, I guess you heard the Brian John's talk, earlier today. If you get the pre-synapse, which are photoreceptor die, you completely miss out the whole retinal circuitry as long as you wait long enough.
Yeah.
But very few people to look at if the post-circuit die, like a ganglion cell die, how much impact is on the retinal circuitry? And there's not very much study on that. So we guys probably have to start from the very beginning to figure out how significant the impact is on ganglion cell. Right. Thanks. Thank you.
All right, so our final talk, Jun Yang is a research associate professor. He's going to talk about understanding the mechanism underlying cone rod dystrophy, and you get extra credit points for being the last person. Let's see if I need to get that.
I like the pink leaves in your picture, Nick.
That's Spiro's Trail in Mid-Mountain in Park City.
Good afternoon. So I'm Jun Yang. So first I would like to thank David Quizard and Nick Magnus for giving me this opportunity to present our research here. So the topic of and eventually, hopefully, we can find some effective treatments for these diseases. So during the past 8 years, we have been focusing on Usher syndrome type 2. We use mouse model to study this disease. Usher syndrome is a syndromic disease, so it's a RP, it's a syndromic type of RP together with hearing loss and vestibular dysfunction. So we found that
genes that encoding that proteins, the positive genes encoding proteins from a complex. So we study this complex in both photoreceptors and also hair cells. So today I will not talk about our research on Usher syndrome. We already published a series of papers. So if you're interested, you can just read our papers. So now we just want to talk about our research on cone rod dystrophy. So about 4 years ago, we became interested in cone rod dystrophy and started a new research project. Compared with RP, cone rod dystrophy, CRD is a rare disease, so it affects 1 in 30 to 40,000 people worldwide. However, compared to RP, CRD has more severe problems. So, what's CRD? So, unlike RP affects the rod photoreceptors first, and then cone photoreceptors. And CRD affects cone photoreceptors first, and then rod. And sometimes CRD can affect both rod and cone photoreceptors at the same time. And also CRD can be inherited with all three Mendelian patterns of inheritance. So although right now up to 30 positive genes has been identified for CRD, and the genetic causes of more than half of CRD cases are unknown. And for the identified genes, quite a few, we don't really know their biological functions, or very limited information about their biological functions are known. So in my lab, we interested in C8of37 gene, which was identified by Estrado Cascano et al. In 2012. And since then, more than 8 more papers has been published to report more C8of37 mutations and also patients in different ethnic groups. So here I just show you the mutations identified right now in C8of37 gene. So we can see that the mutations distributed throughout the gene, and they include splice site mutations, nonsense mutations, missense mutation, and also fringe mutations. And these mutations can cause, CRD and RP, and also RP together with early maculopathy. And also you can see it also can cause Barbido syndrome. So Barbido syndrome is another syndromic form of RP, which is characterized by RP together with obesity, renal problems, polydactyly, and cognitive deficiencies. So at the protein level, this protein has 207 amino acids in humans. However, the challenge to understand the function of this protein is that there is no known functional domains, and also there is no known similar proteins. So right now, this protein is just named by the position of the gene in human chromosome 8. So, but when we align the C8of37 protein sequence from mammals to lower eukaryotes, we found that the C-terminal region of this protein is really conserved. So indicate that this protein probably play a role in a very important processes. Okay, so what's the function of this protein, and why mutations in this gene can cause retinal degeneration? So first, we just set out to set up an animal model to study this question. So we set out to generate the C8of37 knockout mice using CRISPR-Cas9 technology. So by using 2 small guide RNAs targeting exon 1 and exon 5 of the gene, we generate 3 mutant mouse lines. So the first one has 6 base pair deletion in in exon 1, that also including this translation start codon ATG. And the second has a 10 base pair deletion in exon 5. And third has a large division between exon 1 to exon 5. And then we did the immunoblotting analysis. We found that all three mutant mouse lines, they don't express C8of37 full-length or truncated proteins, indicate that these three lines are complete KO mice. Okay, so then we assess the retinal function of these knockout mice using electroretinogram ERG at 5 weeks of age. So we can see that all three mice, so the red color is one line, green color different line, the third line is blue color, and also the dashed line is mutant mice. So we can see that all three mutant knockout mice have about 50% reduction for scotopic A wave amplitude, and also 50% reduction of photopic B wave amplitude, indicating both rod and cone dysfunction. And then we just focus one mouse line because the three look same, have the same retina phenotypes. So we focus on one mouse line. We test ERG at different ages, and we found that both rod and cone dysfunction show a progressive trend. And then we asked whether these mice have retinal degeneration, because sometimes the retinal function has a problem that the photoreceptors, the number is okay, they're still alive. So first we use this non-invasive approach, the OCT approach, to study the retina. So compared to the control retina, we found that in the knockout retina, at both 2 months and 6 months of age, this out segment and inner segment junction line is missing. And also, at the 6 months of age, this photoreceptor nuclear layer is much thinner compared to the control, indicating retinal degeneration. Okay, and then we did the standard histological analysis using light microscopy, and the result just confirmed our OCT finding. So you can see that the outer segment layer and this outer nuclear layer get thinner with age. So at the beginning they're fine compared to the control. And eventually the outer segment is disappeared. Okay, however, we found that both female and the male mice, they don't show obesity up to 6 months of age. And also, they don't show these polydactyly things, which are characterized as Bardet syndrome patient symptoms. So in summary, for this part of our study, so we successfully generated the C8of37 knockout mouse models. And these mice show both rod and cone dysfunction and progressive retinal degeneration. However, they don't show other symptoms outside the retina. So these models are good animal models to study retinal degeneration in C8of37 deficient patients. Okay, so with these mice, we asked the question, so why C8of37 mutations or knockout can cause retinal degeneration? So we first look at examine the photoreceptor morphology by scanning electron microscopy. So at both postnatal day 10 and 30. So compared to the control photoreceptors, we saw this the knockout photoreceptors show abnormal outer segments, which is here. So these outer segments show are thicker and less uniform in diameter and also less densely packed. And then we want to know what's happening inside this outer segment. So we did a transmission electron microscopy. So this is just a control of the segment. So as expected, we see membrane discs are tightly stacked and they horizontally aligned. And in the knockout of the segment, we see some membrane, this is probably not disc, just membrane things, they very long and they vertically aligned. And occasionally, we do see these membrane walls in this outer segment region, and also this multivesicular body-like structure. And however, the other cellular structures and also the compartments are normal, so such as this connecting cilium, basal body, mitochondria, and ciliary roulette, and even Golgi apparatus, and also the synaptic terminal, they look fine. So when we zoom up to look at the membrane discs in the knockout of the segment, we see that this is horizontal membrane. They kind of grow, overgrown at the plasma membrane region, and then turn vertically. And also we try to look at the horizontal discs and the vertical discs, and we don't see plasma membrane in between. So this suggests that the horizontal and the vertical discs, they are wrapped by plasma membrane inside the same outer segment. So this can explain the phenotype we saw in scanning electron microscopy. The outer segment is thicker and less uniform. Okay.
June, I just want to clarify that the heterozygous knockouts look like a wild type.
Yes.
Okay.
Because this disease is for C8orf37 mutant mice is autosomal recessive genetic disease. So for the het mice, we see the not really phenotype. We see the structures is similar as wild type. So we consider this control. Okay. So and then we did a series of immunoblotting analysis, and then we found that many outer segment membrane proteins and associated proteins, their expression level decreased, which I marked here in red. And other proteins, they're okay. They has the normal expression level in the knockout photoreceptors. And also I marked these proteins, I circled these proteins in green. So these proteins are encoded by known CRD positive genes. So this indicates that the mechanisms of CRD pathogenesis in patients with C8orf37 mutations probably shared among patients with mutations in these genes. Okay. So, and also in the field, it's known that the RDS, GAP2, and CNGP1 are involved in organizing the outer segment discs in photoreceptors. So the association between the RDS and the ROM1 oligomers with this CNGP1 can link the membrane discs to the plasma membrane. And also the self-interaction of GAP2 is responsible for disc stacking. So we found that the reduction of GAP2, CNGP1, and RDS, so that can explain why we see that the membrane disc misalignment in the knockout of the segments. So now we know why this C8orf37 knockout can cause retinal degeneration. However, we want to know now why C8orf37 knockout can cause off-segment membrane protein reduction. So this is, we're still in the process trying to understand this question. So right now there's no clear answer to that, but I just share with you our preliminary data. So first we want to know where C8orf37 protein localized in photoreceptors. So we did immunostaining of C8orf37, and we found that the green signal is from C8orf37 staining. So we found that this protein is localized throughout photoreceptors, but It's not in outer segment. However, in the knockout mice, we also see this kind of signal pattern. So in that case, like this indicate that the signal we see in this control retina is probably from specific C8 OXA7 signal, but also mixed with non-specific, unknown non-specific signals. So to verify the localization of C8 OXA7 in photoreceptors, we collaborated with Arshavsky's lab. So we did a tangential section of retina, and then we examined where C8 OXA7 is localized in every consecutive retinal sections. And here is the result. So basically, this RDS labels where outer segment is, and then for transducing is localized where photoreceptor is except the outer segment. So we see that the C8 OXA7 is in the inner segment, not outer segment. So because like we know knockout of C8 OXA7 can reduce outer segment membrane protein. So what's going on? So it's possible that we know that the outer segment membrane protein is synthesized in the inner segment and is transported to the outer segment. So that means something went wrong during this process, synthesize and then transport to the outer segment in the KO mice. Okay, so we did image staining of all, not all, just like several of these outer segment membrane proteins. We know they reduced in the KO mice. However, we found that most of them are just localized normally in the outer segment. So this indicates that the C8 OXA7 probably not involved in the trafficking to the outer segment. And also we found that the outer segment membrane protein reduction occurs at the P5, postnatal day 5 during development. And at this time point, photoreceptor still differentiating. So the connected cilium is forming, but the outer segment has not been formed. So at this stage, there's no outer segment, but the outer segment membrane protein already reduced. So this also suggests the idea that C8 OXA7 is not involved in outer segment membrane trafficking. So now we think it's probably something wrong with protein synthesis or degradation. So we still try to do the experiment to detect, like to diagnose which part is really has problem. So, but we in our lab, we also try to identify C8 OXA7 interacting proteins. That will tell us what cellular process the C8 OXA7 plays a role. So we did a series of proteomic analysis using mass spectrometry. So we did this mass spec study on proteins that immunoprecipitate by C8 OXA7 antibody from mouse retinas. And also we did pull down using GST tag C8 OXA7 protein from bovine retinas. So, and then we did this 5 times. So each time we definitely have negative controls. So compared to the negative controls, we have these unique proteins identified by mass spectrometry. So that's a lot of proteins. So, and then we just think if there's a real interaction, it should be show up multiple times. So, in fact, we don't see one protein that show up all 5 times. So, but we do see one protein here, it show up 4 times, even across different approaches from mouse and bovine retinas. So this protein is interesting. So it's encoded by a known cone rod dystrophy gene. However, this protein, the function of this protein is not really well studied. So from this, if this interaction is true, we still don't know what's the function of C8 OXA7. But these 3 proteins is interesting. So the KTN1 is on ER, so it's a membrane protein. It can anchors the protein translation factor 1 complex to the ER. And in culture cells, knockdown of this protein can cause membrane protein synthesis reduced. And these two proteins they both have de-ubiquitination activity. So it suggests that this protein is involving protein-some degradation pathway. So that from this study is also kind of suggests two directions, protein synthesis or degradation. So we need to further to at least confirm this interaction and then have some clue what really went wrong in C8 oxygen 7 knockout mice. Okay. So in summary of my study, hopefully this is just last part, right? Just 2 more slides. So first we successfully generated the C8 oxygen 7 knockout mouse model. This model good mouse model for future mechanistic and therapeutic studies for retinal degeneration caused by C8 oxygen 7 mutations. And second, C8 oxygen 7 knockout can cause the outside membrane can cause outside membrane protein reduction, which leads to outside membrane misalignment and eventually retinal degeneration. And third, C8 oxygen 7 is in photoreceptor inner segment, so it may be involved in outside membrane protein homeostasis, but it's probably not involved in trafficking. And finally, the mechanisms of retinal degeneration in C8 oxygen 7 deficient patients probably is shared among other CRD patients with mutations in other genes, such as RAP28, GC1, RDS, ABAC4, etc. Yeah. So finally, I'd like to thank the people involved in this study. First, the people in my lab, they really work hard, and especially Ali Sharif, he is a grad student in my lab, and the work I presented here was done by him, and of course with the help with other people in the lab, especially Dongmei Yu also did a lot of work here. And Robert Mark and Brian Jones' lab help us to do the T-Young study as a core facility for the department. Wolfgang Beer and Wu-Xing shared their preliminary data on the RAP28 studies. And Susan, so this is on campus, not in Moran, this is Moran lab. So Susan and the team, just like a running core facility, help us to generate the C8 oxygen 7 knockout mice. And Chris Q, J.V. Belknap, and Dennis Winch, they help us to study the biological properties of this protein. So I didn't present data for this part of research. Outside the university, Vadim Ashad's lab at Duke University helped us to localize the protein in photoreceptors. And Bill Houseworth at the University of Utah helped us generate the AAV vector covering this C8 oxygen 7 cDNA. So we're going to use it to study the therapeutic, just go to that direction. Okay, so thank you for listening.
Questions? Yes.
So June, the C8 mutations cause Bardet-Biedl syndrome in humans, but it looks like in mouse, it just affects the eye. It doesn't affect the kidney or the...
Yeah, so because like Bardet-Biedl syndrome paper, there's one paper said that mutation can cause Bardet-Biedl syndrome patients. So if you, let's see, if you look at that, it's like the same exact mutation in another paper. It said it's just involved in CRD. So, here, the exact mutation, two groups, one said is CRD, the other said is Bardet-Biedl syndrome. And this group, Bardet-Biedl syndrome group, at our meeting, they once present their posters. And when they present their posters, they said that patient has exact mutations in Bardet-Biedl syndrome called BBS4. So that's probably, so for these Bardet-Biedl syndrome patients, probably the symptom is it's kind of like also caused by that the hypothetical mutations of the other gene. Yeah, so that's kind of right now we think is kind of like that.
Hey, thank you. So I want to thank all the speakers that were involved and thank everybody who helped us to put this meeting together. Our photography department, our administrative department, I mean, everybody who was involved with this. Thanks for a successful session, and you will